Ừ. Ừ. I'm sorry. Use the mic, the mic because of the online attendees so that they can hear you.
Okay. Okay. Good. Okay. So I think we can start. Good morning. Welcome to this session dedicated to lifestyle medicine. And we have Dr. and Professor Mladen Golubic of University of Cincinnati today with us. Mladen was a keynote speaker at our last symposium in Pittsburgh last year. It was a huge success. And then, of course, we invited him to come specifically for this patient and family session. As we know, this is a unique aspect of Camden GVG Symposia, that we have this patients and families sessions and everybody together, what creates this unique atmosphere where we keep coming back and back for 15 and plus years. So just say a couple things about Dr. Golubic to make sure he's the Osher Center Distinguished Professor and Medical Director for Integrative Health and Family and Community Medicine at the University of Cincinnati, where he has been since January of 2021. Prior to this, Dr. Golubic dedicated 3 decades at the Cleveland Clinic for fulfilling dual roles as a scientist and the dedicated physician in patient care. Dr. Golubic started his training and whole work for all these years at the Cleveland Clinic with some of the pioneers that really laid the foundations of what we call lifestyle medicine today. We hear more about all the pillars and things that you're going to recognize that in daily practices and patients and clinicians, we have similar questions, and I think we heard some very good answers. We look forward to some time for questions after the presentation, so please think about how we can interact. To be added is that Dr. Golubic is a graduate from Zagreb School of Medicine in Croatia, and where he did his PhD. He did his PhD for 5 years at the Max Planck Institute in Germany. And just needless to say that he presents all over the grand rounds at the conferences and public events on the topic of lifestyle medicine, and we just look forward. Thank you, Mladen, for driving from Cincinnati and being here with us today. Welcome.
Thank you. Yeah, thank you very much, Dr. Pavletić. Thank you very much for having me here. I have a lot of slides, and I'm hoping that we'll be able to create like PDF and send with everybody who was there. So that's why I included, but I'll go very fast. Since we are running short on time, I'll skip some of the short videos. And I think the nicest part of these presentations is answering questions, because you might have different interests. So let me move to the side so that I don't obstruct the view for anybody. So this is the definition of lifestyle medicine. Essentially, paying attention to the things that we can do for ourselves, self-care, yeah? All the things that are important, food and movement and sleep and relationships and so on. The difference is that in many other specialties, this is not the primary therapeutic modality. In lifestyle medicine, that's the primary. This is a complex slide. I want to make a couple of points here. These are 6 pillars of self-care, of lifestyle. 7th one, unofficial, being the nature. And they all interact. If you want to impact inflammation, inflammation is a big thing in any disease, and especially in blood cancer field. You can do this through changes in your eating habits. You can do this through the meditation, stress reduction practice. You can do it through the physical activity. You can do it through sleep. So the point here is that you might not be super excited about changing your eating, but you want to focus on improving your sleep or your physical activity. you know that you will impact those key pathophysiological mechanisms in synchrony with other. Yeah? And all of these things are very important for just maintaining the health and even if sometimes reversing the disease. So these are all the conditions for which lifestyle medicine is of use. Of course, we'll focus on cancer and specifically on blood cancer. Again, it's universally recognized that we really need to focus on enabling quality of life and good orientation towards healthy living for any cancer survivor. And this kind of now extends from the oncologists to primary care and collaboration with experts in nutrition, exercise science, behavior change, and I added here culinary medicine because often it's very important not just to know which kind of foods to eat, but how to prepare them so that they taste good. So this is a review that Dr. Pavletic, his group, we put together. So I will not go into big details. The point one is that there is people with blood cancer who really have the same issues with chronic diseases like anybody else. And in addition, they are at high risk because of the treatments that they receive. Yeah? This kind of summarizes how prevalent is the risk of cardiovascular and metabolic disorders for patients with after the stem cell transplantation. And what is very interesting is this collaboration between pharmacological interventions and lifestyle. They are not mutually exclusive. The best is when you combine them both. All those risk factors for cardiometabolic diseases, yeah, heart attack, stroke, can be mitigated by lifestyle changes. So we know how we can even arrest the progression of diabetes. We just talked earlier about Dr. Kim Williams, past president of the American College of Cardiology, who said, can we put cardiologists out of business in 10 years? Yeah, that's how powerful lifestyle is. And that's based on the work of dear colleague and mentor, Dr. Esselstyn, and then Dr. Dean Ornish. They have shown that you can, through lifestyle changes, even reverse advanced coronary artery disease. And last year, Dr. Ornish published a randomized study where they looked at patients with early dementia, early Alzheimer's, and showing that when you compare the control group for 20 weeks, their scores on cognitive performance worsen. Higher means it's worse, and intervention group improved. Yeah, so this is the first time that you can take a chronic condition such as early dementia, and through lifestyle changes, you can reverse it. So tremendous potential. Now, why this is important for anybody with blood cancer in general, because there is a common cognitive dysfunction, fatigue, disturbed mood, and sleep. So through all of these mechanisms, a lifestyle intervention can help. Now, this is really the main point of my presentation, and that is people know that it's a good idea to move and to eat well. It's just that I don't like to do that. Yeah, this doesn't taste good. Yeah, I'm too tired to do 5 minutes of meditation. Yeah. And this is very, very common. So I'll quickly go through some of those things. I will look here that I don't overdo, and I'll skip some of the slides. I want to mention 3 principles. So no matter what, yeah, if you want to change anything in your self-care, you have to start experimenting. You have to choose where you will do things differently. And it can be 5 minutes, 3 times a week of something new. Yeah. Evolution, meaning progress, not perfection. You do not jump from here to there overnight because usually it's not sustainable. It can happen, but the most effective is that you learn maybe 1 new dish in a month. In 6 months, half of your diet is different. Yeah. And so on. So let's look here at physical activity. I think needless to say, so there are studies, and I'll skip those. that when you engage in physical activity, here they looked at 11 of those studies, you improve, yeah, no matter in which phase of your disease you are. And then this is one for patients with multiple myeloma. Yeah, how important is this was randomized study, small study, 34 patients, and almost anything that they measured was better. Yeah. You can see here all those symptoms that improved, and their treatment was more successful. They didn't need to change the doses. They had less side effects, and they felt less fatigue. Look at this, 6% versus 75% in fatigue, and this is very, very difficult to do. Yeah, so you know, and this was not super, intensive activity. Yeah. I'll skip this study. This was with breast cancer, showing the same benefits. Now, American College of Sports Medicine says, almost anybody will benefit from moving more. Yeah. Now, there are always excuses. I'm too old, I cannot do this. Yeah. So we just immediately tell our patients, that's what we expect after, 6 weeks. I want just to mention this. What do you think is the percentage of people who use escalator versus stairs? Or let's turn it around. People who would use stairs when they have opportunity to use escalator. It's 2%. If you are the conference of exercise physiologists, it will be 8%. Okay, so we are wired to sit, and if there is one book that I would highly recommend, then this will be this one, Exercise, by Professor Daniel Lieberman from Harvard, professor of anthropology. This is how we are designed. When we don't need to hunt or gather the food or chase the mates, we do not spend energy. We do nothing. Okay? So, and we have environment, we created environment where we do nothing. We are not forced to do anything. Yeah. So just to tell you that you don't need to feel guilty, oh my God, I don't like to exercise, but you have to consciously make steps to do that. And American Society of Clinical Oncology, Society for Integrative Oncology suggests that if you have anxiety, depression, whether during active treatment, post-treatment, those are the activities that you can do. Low intensity. Gateway exercise is acupuncture, yoga, tai chi. Yeah. And then there are other modalities that you can use. For you, if you are excited about trying some yoga, for example, through the Osher Collaborative, our yoga therapists and the one from University of California, San Francisco, created a set of short videos, 5 to 12 minutes, yoga for different issues that we might have. Yeah, fatigue and sleep and pain and so on. And it's very easy. You can just take this QR code, or you can just Google, and it's on YouTube. And if you do not have, opportunity to go to local yoga classes, you can do that. Yeah, you just choose and practice. So we'll move here. Ideally, you want to move in the nature, right? Whenever you can. Now we are sitting here, and maybe at the next meeting there could be some activity, and we'll have some sound bath and so on. So people who spend at least 120 minutes in nature, they enjoy better health, period. And this is per week, 120 minutes per week. That's not difficult to achieve. There are even studies that if you take a walk outside for 15 minutes versus 15 minutes indoors on a treadmill, and then somebody tests you, give you a test, how fast you answer the things on a computer, how many mistakes you do, you will do better if you do 15 minutes outside. It's quite impressive, yeah? This came yesterday in my email box. It says, it's here, Nature as Medicine goes live. We are doing this already for a month, but it was an official University of Cincinnati protocol. And I have a short video, which I will not play for obvious reasons because of the lack of the time. So I will just skip this. But for you, what is important, if you want to know how you can engage, you can scan those codes and you can learn more about nature as medicine. It's the 7th pillar of self-care. I'm sorry, I will go back, but this should be in your PDFs, and you can always look into that. Sleep is common. I don't need to tell you about it. If you a patient or caregiver, I mean caregiver meaning co-patient. Yeah, so the same thing. You know what I mentioned here. It's valid for both groups. So almost 40% reported issues with sleep, and that's not surprising. Yeah. So what can we do about sleep? The key is to be in circadian synchrony. Yeah, and here it's unbelievable. About 10% of all the genes that we have are regulated by these day and night cycles, yeah, circadian rhythm. And here are some, evergreen suggestions, what to do. Exposure to bright light early in the morning, it's quite valuable. Like, for example, if you walked outside today for maybe 10, 15 minutes when the sun was getting, it was just perfect right before, or just the daylight was coming. That's very important to set up our circadian clock. And ideally, you want to wake up hungry and then eat good breakfast, and we had some good stuff there. In the afternoon, you want to warm up your core body. So get out, start moving 2-3 minutes, some yoga stretches, couple of wall push-ups, eat light dinner, and avoid bright lights. Don't work on the computers. Put the mode where you can tone down the blue light because it will disrupt your sleep. That's how I feel on many days. It's a new science of stress. Yeah, I'm sure we all feel that way. Yeah. So here is what we can do about it. Now, for you as patient, clearly there is a lot of anxiety. I need to have all those procedures. And when I was at Cleveland Clinic, Diane Dushek, who was a nurse at the GI department, she ran a randomized study with patients who were undergoing GI surgery, who were listening to guided imagery, stress reduction practice. They reported after surgery less pain, less anxiety, less use of medications for pain, and they were discharged 2 days earlier. Then the CEO of the hospital, who was cardiothoracic surgeon, said, that's not true. I want to see this for my patients. So they repeated their randomized study, and the same thing happened. Okay? So it's very powerful, just stress reduction. Yeah? So this is that guided imagery. Yeah? And we can do that with the practice. Yeah? The more we practice, we can do that. Why it's important to focus on this? Because when you practice those techniques, we become more flexible in our beliefs, in the things that we take for granted, the patterns that we run. And we kind of are more malleable to start eating different foods, or to start maybe, exercising more, or being more social. Greatest stress reducers, friends, purpose in life. Physical activities is a great stress reducer. And the last one is that you practice how to elicit that rest and digest and repair a relaxation response. That is opposite from stress, fight or flight response. We can do that. Yeah, this is part of who we are. Yeah, we know that breathing, if we breathe if we are under stress, we breathe different ways. If we are kind of relaxed, our breathing is different. Pay attention to that. Yeah. So our ancestors, thousands of years back, said, what would happen if I change my breathing? Would I feel differently? Yes, absolutely. By changing the breathing patterns, you can enhance your energy, you can calm down. Yeah? These are a couple of links here to very simple breathing practices. And on this yoga 5 to 12 minutes videos on YouTube that I mentioned earlier, there are also 2 of them with just focused on breathing techniques. So you can practice that. Yeah, maybe that will be something that will excite you. Here is a very good formula wherever you are, whether you're a dentist, whether you're undergoing procedure, whatever you do, you just remember that you are breathing, that you are here. It's the simplest, always available stress reduction tool. You don't need any apps. You don't need anything. You just need to pay attention and notice that you are eating. Yeah. I'm finally learning how to relax. Unfortunately, relaxation makes me tense. Yeah. Anybody in that category? Yeah, we feel guilty. This is not natural for our society. Yeah. I have so many things to do. I cannot do nothing. Yeah. So those techniques will also help you with this. These are all the positive things that happen when you practice some of those techniques. This was mindfulness-based intervention for caregivers who are equally stressed, sometimes more than the patients themselves. And it really shows how you can improve your well-being just by simple techniques such as mindfulness practice. These are all the classes that we offer free for our patients. So yoga, Tai Chi, mindfulness meditation. Every Monday morning at 8:30, Dr. Walker teaches Mindful Mondays. Anybody, you can live in Australia, you can join, scan the QR code, and you can be there. And then there are, on our website, there are pre-recorded practices again. Somebody likes male voice, somebody likes female voice, somebody likes music, somebody doesn't like music. You can find any of those. The key is that you find the practice that resonates with you. I will also skip that one. And the last couple of things about foods. So we will go to the non-fiction side, okay? A lot of us go to the fiction side because people write books, they write, they do some simple, literature reviews, and they are the experts. So what should we eat? That's a big question. We have pretty good ideas. What should we eat as a group? Yeah, I mentioned to you earlier, yeah, you can reverse diabetes through dietary changes and heart disease. But this is as a group. Not everybody reacts the same way. So there is a huge NIH study, National Institutes of Health sponsored study called All of Us, where we will have those answers. Right? And very, very detailed study that we will know what is the best food for you at this time and for me at this time and what will be down the road. Now, we are not there yet, okay, 24th century with the food replicator, yeah, we will eventually figure that out, how to do that, but we are way far away from it, yeah. The best what we can get is the experts who every 5 years do the dietary guidelines, and you can see that it's eating more vegetables, fruits, legumes, whole grains, some fish, vegetable oils, and then reducing red processed meat, sugar, sweetened beverages, and so on. Yeah? Again, another set of experts rank the best diets. Mediterranean diet is the best for the past 8 years. Doesn't mean that this is the healthiest diet, yeah, for particular purposes, but it's the easiest to follow, and it has the biggest impact. Yeah, dietary approach to stop hypertension, very similar. Flexitarian diet, you can be plant-based, you can add some animal foods. And then this one, that's American College of Lifestyle Medicine. So the more you move here, the more benefits you will have. And I will skip some of those studies, but I wanted to show you how powerful it is when you are fully on that side. And Dr. Shah is there, and she can tell you everything about fully plant-based eating. So if you have questions about this, grab her, and she will inspire you so that you eat fully plant-based, all right? Yeah, that's okay. Thank you for being here. Yeah. I will skip this. So the only side effect of eating all plants is this one. Some people worry when we eat a lot of fiber, we'll have a lot of flatulence, and that will contribute to global warming, okay? I don't think you need to stress about this, lose the sleep, because the major contributor to global warming are farting cows and burping cows, okay? Because they release a lot of methane. So don't worry. I mean, this is yes, if you start eating more fiber, you will have more gas. But if you are moving, you will not even notice that you have it, yeah? Now, here is the question for you and for everybody is, why do we still continue eating unhealthy diets? Who doesn't know that eating more vegetables and fruits is good for us? Is there anybody here who doesn't know that? Yeah. Only 10% of people in the state of Ohio take 2 servings of fruits and 3 servings of vegetables a day. All right? So 90% do not. Yeah? So we have a lot of room for improvement. So this is how complex that is, what determines which kind of foods we will eat. Yeah? Many, many factors. It's different in different societies, how we were brought up, what are our taste preferences, and so on. So this was done at Purdue University. You can see here that these are the reasons. Some people pay attention to nutrition. They said nutrition is the most important. Yeah, those usually who said my diet is excellent, they pay attention to this, environmental impact. But those who said my nutrition is poor, for them, the most important here is this: is it affordable? Is it available? I don't care so much about, taste has to be perfect, but whether it's healthy, I don't care. Yeah. And here are all the obstacles. Yeah, why we don't do this? I would say, yes, price is clearly obvious. We have totally screwed up, farm bill where we reward raising, foods for animal feed rather than human. But this is where we come in. It's hard to know which foods are healthy. How in the world that can be difficult, yeah? But there is a lot of confusion about it. And also, I don't trust claims about the healthfulness of foods. I mean, if you see, never eat blueberries because of X, Y, and Z, and then the other one says, eat blueberries to prevent your cognitive decline, what do you do? Yeah, so you are confused about it. Yeah? So the point I'm trying to make, this is a wonderful article by Kevin Hall, who Dr. Pavletic know, because he really resigned from NIH because they tried to twist he is like ultimate expert and guru on ultra-processed foods. And as you can see here, this was the article that they wrote. It says it's not you, it's the food, and I added environment. It is environment that we created, yeah. Yes, we do have some, decisions that we can make about choices that we make, but if we live in an environment, we will not do this. When I drive to my work, I pass this advertisement for the UC Health where I work, and it says science stroke is reversed. It's amazing what we can do now, yeah? Modern medicine, it's incredible what we do. But then we do almost nothing about the environment that creates more patients with stroke, more patients with heart attacks, more patients with cancer, yeah? This is the food environment that we created. So that's why everybody has a responsibility to contribute to this, yeah? So don't eat like this. If you remember one thing about foods, chew well, okay? I could give you another full hour about science for benefits of chewing well. Even if you eat green leafy vegetables, don't chew like this guy who is the world champion in collard greens. 2.5 pounds in 17.5 seconds, okay? So you can go on our website and get the mindful eating guide and practice. You don't have to be like a monk or nun in the monastery to kind of say, honey, sorry, I need to chew. But when you get a chance, slow down, okay? In fact, we would need to get 10 servings of fruits and vegetables. And here are some suggestions from the recent Harvard Health Letter, how you can do this. Yeah, so you will have all of this in your handouts. Stock your freezer. Frozen vegetables and fruits are as nutritious as fresh when it comes to anti-cancer compounds. And they are much cheaper and more convenient. Yeah, so always use those. I don't care what the doctor said, refined people don't eat unrefined foods. Yeah, again, we feel like, we are not sophisticated eaters if we eat, the 100% whole grain. Eat beans, feed your gut microbes, and avoid this. Minimize this. It's impossible to avoid it, yeah? These are the things that you and I cannot make in our kitchen. These are 2 wonderful books. I'll skip this. This is what we feed our children. They get 67% of calories from ultra-processed foods, that our ancestors would not know what to do with this. They would not recognize this as a food. Where did we go wrong? Our son, a vegetarian. Yeah, people get upset that that their kids are eating plants, but they totally neglect that they can eat all kinds of very unhealthy ultra-processed foods. So resources for you. At our center, we have two amazing chefs, incredible chefs. Dr. Chef Stephanie Michalak and Pamela Sharp, who is nurse practitioner working with me. They are spectacular. So there is a number of recipes on our website. You can check this. If you're interested in eating like Mediterranean style diet, my former friends, Dr. Mike Rosen and Chef Jim Perko, have like 113 different videos about different recipes. Yeah. And then if you want to be fully plant-based and experiment with this is a wonderful cookbook of a wife and daughter of Dr. Esselstyn. And then there is also Taming Inflammation recipe book by the Cleveland Clinic and Arthritis Foundation that have 23 anti-inflammatory recipes. So there is no lack of recipes, yeah, there is lack of desire to do that. And I hope that you will be inspired to do this. We have also QR code for this. I put this that I'm lucky that I'm not astrophysicist. They don't know anything about what they are studying. At least in our field, we know a little bit more. And I just want to finish with this. Medicine is just one aspect in society. Whether you work in any other aspect, we all have responsibility to enable us as a society to move forward, to create healthier environments, to eat better. This is a new center for blood cancer healing center where we will have from March 1st on the 5th floor, we will have state-of-the-art teaching kitchen. We will have mind, body, spirit room where we will do group classes, and we are looking forward to that. But it has to start with you. So eat plants whenever you can. Keep moving. Make sure that you sleep well, that you are present, paying attention to what's going on, in spite of everything what's happening around us. Yeah, just keep calm and love people. And I think if we do those things, we will enjoy very good health. So I will stop here and I'll be happy to answer your questions. I'm sorry I was speeding up through this, but questions, okay? Let's go. Here is a mic for questions, but for our friends who are online. All right. There are questions. Okay. Yes.
So one thing you didn't talk about was water, drinking water. And I feel like I'm a camel. I just, my whole bone marrow transplant experience was, you need to drink, you need to drink, you need to drink. I couldn't possibly drink, 5 of those a day.
Yeah.
So my question just about water and the importance of that. You didn't talk about that, I don't think.
I didn't talk about it because I don't know enough to be kind of expert about that. In general terms, the sense of thirst is quite basic instinct. Unless you are really in ICU and you don't have good access to water, you'll not have that urge. But for all practical purposes, you'll be okay. Yeah. Now it depends what else are you drinking. If you are drinking the other things like coffee and tea and of course soda, I hope not, that can kind of require more water. Which kind of foods you eat? Yeah. If you eat vegetables and fruits, you have plenty of water there. Yeah. So, but yes, I would just say follow the advice of your doctors, of dietitian. If they said, drink this amount of water, try to get. But clearly, there is a limit to what you can do. No other questions? Everything is clear cut? Yes, go ahead.
You see a lot from influencers, I guess I'll call them, about fasting to get into autophagy. Is that something that you talk about or that you're studying, or is it just we?
Very good question, and I'm glad that you asked this. And as you could imagine, there are so many topics to cover. Yeah. So when it comes to fasting, I'll be, very brief. people have looked into this very, very carefully, and there are many different ideas how you should do this. I would direct you to read the work of Dr. Walter Longo, because they did really the most reliable and very well-controlled studies, both in humans and in animals. And the summary is this, that when you go on a full fasting, that you don't take any food, yeah, you just take the liquids, they have shown that you decrease the diversity of your gut microbes, and it takes time to recover them. So what they devise a system where for 5 days in a month, you cut down on calories. You still feed your microbes, but just less calories. And then you repeat this over 6 months, and they have shown through a number of markers that look really very promising. And there are a couple of publications with Italian group where they follow 200 patients with different types of cancer. There was none with the blood cancer, showing the benefits in the immunological response and also in their outcomes. So Walter Longo, of course, what it happens when you create something like that, then the institution where you work, they want to patent this. So there is like prolonged, they said people don't have time, to cook for 5 days, some vegetable soup and eat some handful of walnuts. So we will send you the meals. Yeah. So there is this commercial, thing there. But that would be my advice. But nothing happens if you fast for a day. I think it's, it depends where you are. Yeah. If you are in the recovery phase and you're able to exercise and you sleep well and so on, then you can experiment. I would not do this, put extra stress. If you are really just recovering, I think it's you need food, you need good food. And just chew well. Yeah. Yes.
Regarding keeping storage of frozen fruits and vegetables,
Mhm.
should there be a concern about whether they're organic or not in terms of the pesticide
Mhm.
concentration?
You ask all the amazing questions that I didn't have time to cover. Thank you for that. Yeah. So, in ideal world, yes, it's better to use something that has less of the chemicals. However, again, another thing you can write down, Environmental Working Group, EWG.org. Every year they go to the grocery stores and they sample the produce, fruits and vegetables, and said, which ones have the highest level of pesticides? So they created a list, dirty dozen. Strawberries, some of those berries, usually they're apples. Yeah, they are heavily sprayed. I mean, if you grow apples in the state of Ohio, you have to spray. If you don't do this, fungus will destroy your orchard. So if you can, then try to cut down on those. But then there is clean 15, those that have minimal amounts. So why would you spend money on something like that? If you buy frozen blueberries, you can buy organic, wild frozen blueberries maybe for a third of the price than you would buy regular ones from Peru, or they already, coming from still the local harvests are done. Yeah, so they are coming from South America. So yes, in ideal world, but it's much better that you eat fresh. If you go to local farmers markets, many of them are not organic, but they use minimal amounts of. It's very hard to be certified organic. Yeah, it's a long story, but yes, when you can, if you can, I think that's secondary. The primary is make sure you eat a lot of. When you eat vegetables, fruits as a dessert, 100% whole grains, any kind of beans, lentils, peas, chickpeas, hummus, tofu, tempeh, and nuts and seeds, and then you add whatever you desire from animal foods, small quantities. Okay, I think we're out of time, no?
Yes, unfortunately.
Thank you all. I
Thank
hope
you.
you'll experiment with some of those things, and I'll be around if you have more questions. Okay.
Thank you.
Thank you.
Yeah, just use it. Okay.
It's lovely to see everyone. Thank you for being here. I'm Dr. Hannah Chen. I'm one of the BMT and GVHD specialists at Ohio State. We have the OSU Multidisciplinary GVHD Clinic as a resource here locally if you do live here locally. And I'm very happy to then introduce one of our partners in that GVHD clinic, Kristen Chadwick. So Kristen Chadwick is one of our beloved occupational therapists. She graduated with her bachelor's degree of science from Ohio State University in psychology in 2017. She continued her education to earn her doctorate then in occupational therapy from OSU as well in 2020. And she's worked in multiple therapy settings such as skilled nursing facilities and outpatient therapy, which includes building expertise as a certified lymphedema therapist in oncology as well, and orthopedic and neurological conditions. So Kristen likes to add more and more specializations and certifications as she continues on in her training, soon to expand that even further within GVHD as well. She continues to be a Buckeye for life, as you can see. She's done OSU through and through, and she presently works for the Comprehensive Cancer Center with us as an occupational therapy therapist in the ambulatory oncology rehabilitation group. So Kristen, take it away.
Thank you, Dr. Cha. Oh, yes, I'm going to need that. Thank you. All right, guys, I'll be perfectly honest. It takes me a minute to settle in. I am a little socially awkward, but it's okay. We'll do it together. I'm also going to try to speed us up a little quicker, so I'll kind of probably speed through some slides. If you guys have questions, please let me know. I like things to be interactive, otherwise it's not fun for us, okay? So a lot of patients realize that there is a brain fog or their brain just a little clunky. I often will use an analogy like steel-toed boots while you're trying to trudge through some mud. And it's kind of what you're thinking starts to turn like. And something that's really interesting about this is that there is a larger name for this condition that a lot of people call chemo brain. But from my perspective, I don't particularly like the word chemo brain. I prefer cancer-related cognitive dysfunction because I do cover a cancer continuum where we have patients who have never had chemo or who are not currently on chemo. So some of you in this room, if you are a survivor, you might still be somewhat on a chemo, but you might not be. And this same condition might still apply to you. And so the definition is here on the slide, but it's really this a condition that describes a memory or a thinking problem that occurs to cancer and cancer-related treatments, okay? And it can impact your ability to carry out daily activities, whether it's return to work, caring for your children or your grandchildren or a spouse, or honestly just organizing your day. So it really, really depends. As I kind of alluded to it earlier, there are a lot of different names for the same condition, which is why I think it's one of the hardest things for us to kind of tease out when you come in for an appointment and kind of discuss. Because if we don't use the same words, it's hard to kind of figure out what we're talking about. So that's why I like the bigger name up at the top, because then we can all use the same words when we're going through all of our appointments across the continuum. So how common is this condition? And truthfully, the statistics are kind of daunting, especially considering that the research behind this condition is now just kind of coming to light. The evidence is strong, but we still don't have a lot of evidence. So the fact that 1 in 9 people will report a subjective cognitive decline, in that it interferes with their social activities, their work, or their volunteering activities. But the biggest thing behind this is the last half of that statement. But less than half of those people report it to a provider. And so this makes me question a lot of things. Is it because I'm not listening well enough when we're in an office room together, right? Or are you guys not as aware of it because we're managing a lot of other things until we get a little further post-treatment, right? So the part that I don't particularly appreciate is the last half of that. But we can really see that the prevalence is really strong, where up to 70 to 75% of cancer patients will experience this cognitive decline. And the biggest thing too is that it can last 5 to 10 years after active treatment. So it doesn't just go away, right? And so that's the biggest thing that I like to point out, is that we can kind of help you through all of those things. But specifically, because we're all here for the GVHD symposium, I wanted some statistics just within kind of that realm. And the thing that's really interesting is that it's going to impact your independence as well as your sense of personal agency. Those are really big things that make you who you are, right? And so that's why I care about it so much, and that's why I'm so passionate about it and want to be able to come and help you all. And it's estimated that nearly half of all of these patients show some change in cognitive function before transplant and after transplant. So again, we're talking a lot of daunting statistics here, and yet I still have openings. So what can we do to kind of make that gap, bridge that gap for us all? And then after 3 years, we see that global cognitive impairment rates were about 18.7% who received an auto transplant versus 35.7% who received an allo. So those of us who are getting allo transplants were a little bit more at risk for it. But good news, I'll give you some strategies to help you before you leave today, because I don't like my patients or anyone that I meet to leave without something, right? And then we're starting to recommend cognitive assessment annually. So kind of keeping that trend alive, okay? So this is a laundry list of some symptoms that people might be experiencing. It is not a one size shoe fits all kind of situation, but it is pretty common. Sometimes when my patients come to me and I'm doing an evaluation with them and we're kind of talking about the things that they're experiencing, I look at them and I say, okay, well, you're abnormally normal. All right. So just anyone walking down the street, probably not going to be experiencing what you're experiencing. But in my world and with other people who have experienced similar things as you, very run of the mill. So I think that gives comfort to what you're experiencing, because I think with cognitive decline, people will sometimes try to mask it because they're concerned or they're embarrassed or they're afraid. But in reality, if we start speaking up about it, you're going to find someone else who's experiencing something a little bit different, something similar to you, and then you can get some help from some supportive services. So what causes it? And that is what everyone wants to know. And to be quite truthful, everything causes it. It's very, very difficult to tease out one thing specifically. So I usually look at my patient and I go, it's the chicken or the egg. I'm not really sure. And maybe as research does progress, we will be able to definitively target one thing or the other. But right now, there are a lot of causes and like things that can make these cognitive changes a little bit better or worse for you, depending on where you're at and what you're experiencing. As we've discussed, chemo is a really common one that people really kind of perseverate on, which is so true. So that's why it's on my list. But other things that I usually like to kind of point out that are a little bit more unique are steroids, because a lot of our patients get high-dose steroids and then they progress to low-dose steroids if we can't fully get them off of steroids. But there is a very common brain fog that is associated with steroids, specifically within that larger category of medications, okay? If you're having other types of treatments, those kinds of things, depending on where they are, can impact your cognitive capacity, but some of that is also related to the fatigue of those other treatments. There's usually a really strong relationship between your physical fatigue as well as your cognitive fatigue, okay? And then the last bullet point that I really like to point out, because I don't think a lot of people talk about it enough within our realm, is the mental health piece behind things. So if we are too busy trying to manage our emotions because we've been going through a lot over the last year to 2 years, we just don't have the capacity to think and problem solve and do all of these executive function things that are behind it. So that is why having very lovely support systems and good emotional regulation techniques is really important from a cognitive perspective as well. When we talk about this list, and I think it might be upcoming in a slide or two, let's see, right here, if I back it up a little bit. We are like 3 to 4 spheres. I don't necessarily use all of those words, but I like to say like we are our cognitive health, our physical health, our spiritual health, if you identify spiritually, as well as our mental health. And we can kind of see some of that popping up in this article that we see all of these things overlapping. And our goal is to help all of those kind of be overlapped fully so you can have the best quality of life. But dependent on where we're at in our treatment or what's happening to us personally, we might feel one of those spheres starting to pull away. And our job, as like for myself as an occupational therapist and as your medical team as a supportive service, is to come in and try to help get those spheres try to like overlap again, right? So we're trying to beef all those things up so they're stronger and can pull one thing back in so you can have that better quality of life, okay? as we continue on, specifically within GVHD, because again, we're here for the GVHD symposium, these are a lot of medications that our patients are put on to kind of help manage the effects of GVHD. And a lot of them cause a brain fog. And a lot of the times we're on these medications for a very extended amount of time. And the benefit of being on these medications is definitely worthwhile. So how do we manage the brain fog? Because the medication probably is going to be there at least for the foreseeable future, right? And so I think it's really important to highlight this and kind of see what some of these cognitive side effects are. And I won't read them all just for the sake of time, but you're more than welcome to take a picture of it. Because if those things are you, it might be worthwhile to try to seek some intervention to try to help manage it. So risk factors, and our friend who was kind of talking about it earlier with like environmental and diet things, right? Like we have a lot of risk factors that also influence besides just what's happening inside of our brain. And I'll talk about the elephant in the room. The older you get, the more likely you are to have age-related changes. And that's not super fun, right? But that's part of our job, is to try to help mitigate those age-related changes and help bridge the gap between normal age-related changes as well as what is happening from like a cancer and cancer treatment perspective. If you already had difficulty with like memory, anxiety, any type of cognitive or executive functioning, those things are likely to just be exacerbated. So I usually give an example. I am terrible with names, and I also am a little squirrely. And if you see me at like 3 p.m., you're probably going to see me really squirrely. If I were to be going through all of these things that my patients are, I'm likely going to have just a lot more difficulty with both of those things. So it's just going to be a lot more amplified, okay? When we're talking about pain, who in here has chronic pain or just kind of wakes up feeling kind of gross in the morning because they're kind of stiff and their pain is not there? Okay, right? Especially the older we get, the more likely pain is here. I usually say that pain is like a constant fire alarm going off in your brain. And it's not appropriate for you to just sit here and scream out, right? Social niceties don't allow you to just sit here and scream. And so what is happening is we're using a lot of internal power to kind of tune out that pain, which means it's taking away from our energy levels or our bandwidth to manage all of the thinking again. So this is where kind of collaboration with all of our other providers to have a good pain management regimen comes in, to make sure that our pain is not too much of a factor when it comes to thinking. But then when we think about sleep and fatigue and diet and hydration, I usually use a really great analogy of, if you put crap gas in a car, what's going to happen with the car? Bad performance, right? Pretty crappy performance. Same thing with our bodies. If we're not properly fueling our bodies, we really don't have a hope of being able to adequately think, okay? So the talk leading right up into this one is really beneficial. And then just trying to have a better, healthier lifestyle where we have good coping strategies, we're doing exercise, all of those things. It will help all of those spheres that we talked about at the beginning start to overlap again and line up, okay? So these are specific ones specifically related to stem cell transplant and GVHD. I will leave those there. Something I would like to point out that is a little different than anything else is the length of hospitalization post-transplant. So at least at the James, our patients are inpatient for an extended amount of time. And what happens when you're an inpatient is you unfortunately are at risk for developing a hospital-induced delirium. So that is something to kind of think about, this whole, what day is it, at the time of day, because everything is kind of like Groundhog's Day there. And then everyone always likes to come in at the most inopportune times to check your vitals, aka the middle of the night. So you're not really getting good sleep, right? So it's kind of perpetuating those factors. So the lengthy hospitalizations aren't super helpful from that perspective. So that's when we really need to start implementing some early intervention, trying to have exercise classes while you're still inpatient, but also doing exercise for your brain during that time. And I promise I'll give you some of those things moving forward. This is my cheesy quote because I'm an occupational therapist through and through, and I truly believe that we are one of the best providers to help you all manage all of those things. And we're going to continue about what OT intervention would look like for your brain. So when I see a patient, and this is kind of for you all too, to take it forward, and we'll do a little bit of all of these today. That's why I have a tall order and talk quickly. But when we work together, the number one step is to put compensatory strategies in place. Does anyone know what those things are? Any idea? Just shout them out. I have a couple of patients in the audience. They should be able to tell me answers, okay? Board games would work. I would actually put that down here in the cognitive retraining aspect. It's more like a brain game. I love a good game night. It gets a lot done for me. Yeah, those ones I would for sure put down here in this half. Anyone have any ideas on the top half? I'm staring you down, patient. I couldn't hear. I'm sorry. Anyone have anything? Yes, make your list. Thank you. She passed. Okay, so like making lists, right? Like that's a very basic one. We'll talk about some other ones. But compensatory strategies, yeah. The human PDA. Who had a PDA back in the day? It's the human PDA, right? Yeah. See, it's a great strategy, but what happens when he's not there? Right? So that's why I don't particularly like that strategy, but it is a strategy. I'll give you that. Pill boxes, yes. Okay, so you guys are getting there. It's not rocket science, but half the time we forget about it, right? And so compensatory strategies are things that we do to offload our brain. So then our brain has more energy to think and do and emotionally regulate and do all the fun things like play games, right? So we got to put the compensatory strategies in place. So then when I get to cognitive retraining, that's really where we treat your brain like it's a muscle, right? And so that's really what OT does when we're working together. And it's really hard to say what I'm going to do every day because each of you is different. Each of you have different life demands. Each of you have different things that are important to you. And so that's why it's not a one size shoe fits all. So we're going to have a little bit of a break for an activity because I like interaction. This is something that I would call as a brain activity or a cognitive retraining kind of activity that we would do together, okay? And so what we're going to do is I'm going to need you guys to match my rhythm, okay? And while you're matching my rhythm, I need you to sing happy birthday. Now, you don't have to be a great singer. I'm not a great singer either. But I just need you to kind of like, happy birthday to you. Happy birthday to you. Okay? You guys got that? Think you guys can do that? But you have to match my rhythm while I do it, okay? Think you can do it? All right. So I'm going to put these down because I need hands. I'm a loud mouth. I really don't need that.
Can you actually speak into the microphone for the virtual attendees? Or do you want me to do something?
What do you mean? Okay, so we're gonna start singing on 3, and you guys have to like match my clap rhythm while you're singing, okay? And you gotta do them at the same time. You guys got it? All right, are you ready? 1, 2, 3. Great job, guys.
Yay!
So
That seemed hard.
how hard was that for you guys? Kind of like on a scale of 0 to 10, 10 being uber difficult, you could never do it again. Why did you make me do this? To 0, I could do it in my sleep and not think. About a 5, a 4, 2. Okay, so we clearly have like a wide range of cognitive ability. It is very hard to come up with an activity with no props that meets all of the demands. So I'm really excited that we have such a wide range of 2, 4, 5s, right? And that's where the skill of coming to someone like me is I'm going to ask you questions like that, and then I'm going to make it even harder if you were more on the 2 edge over there, sir, in the blue. Or if you're more on the 5 edge, that's a perfect challenge for you. I don't want it to be too hard because then what's the point? But I also don't want it too easy because, again, what's the point? And so this is a really great thing of talking about how we're trying to do a dual task where people think that we're trying to multitask in our day-to-day life. Research actually shows you can't. You're usually a little better at shifting gears. But I'm going to force you to try to do that because it's a great cognitive retraining activity where the demand on your brain is a lot more. Okay. So we did a little movement. So that's a kind of like a sneak peek of what a cognitive retraining activity could look like outside of a game night. But at a game night, right? You're talking, you're playing, you're strategizing. It's kind of dependent, right? I see some like dice being rolled, right? There's a lot of things that are happening within that. So that's why a good game night can be helpful and something that's fun so it's not hard to put it in there, okay? For the sake of time, I'm going to skip this part, but there is a holistic assessment that we could do to kind of figure out what do we need to do to help you as an individual. And if you all are looking for services to help your brain fog closer to home, these would be the things that I would probably look for and make sure that is happening when you're going through an evaluation, okay? And we're going to go through all of those. So let's continue. So let's talk about some lifestyle changes, right? So I kind of already talked about all the spheres that kind of need to work together, right? There's a theme. And we learned a lot about a diet beforehand, so I don't need to worry about that topic, right? But exercise. Who exercises in here? Hey, that's like 90% of the group. Okay, so it's great. Exercise is multifactorial. Number one, it's the best way to help cancer-related fatigue. Raise your hand if you have fatigue. Okay, me too. It's Friday. But it really is the number one way to combat cancer-related fatigue. Two, it's really great for your brain because it releases all the good juices in your brain after you exercise, so you feel a little happier, a little more proud. The other thing behind it is it really does help heal your brain, right? It helps kind of increase your arousal in your brain, make sure your thinking go a little bit better. So get up. At least do a little stretching routine to kind of get the cobwebs out of your brain in the morning, okay? So instead of fully caffeine, maybe do a little exercise, all right? We also really want to make sure, again, we're doing strategies to help our sleep and our energy, okay? Doing some like mind-body exercises, mindfulness, yoga, meditation, all of those things are really great because it's helping you reconnect and kind of honestly associate with yourself again. I think a lot of our patients, and I'm going to probably say something I shouldn't, but I think a lot of our patients, in order to cope, just kind of do the next thing. They're not necessarily thinking about what's happening to them, and they kind of become a little disconnected from their bodies and their brains because it's what they need to do. And there's nothing wrong with that, but also too, to help healing, we need that connection to come back again. We need you to learn to listen to your body again so you can advocate for yourself. And that's part of my job, is to help you figure that out. And that's where the mind-body exercises come in. That's where mindfulness comes in. That's where meditation comes in. That's where exercise comes in. That's where fueling your body comes back in, okay? So sleep quality. Get good sleep. Don't sleep with the TV on, please. It's not great. Cool rooms, dark rooms, that kind of stuff. There's a lot we can do. I found that as the older that we get, the less reliant upon a bedtime routine we are, but we're actually all just a bunch of babies in adult-sized bodies that need to have a better sleep routine, okay? So if you need tips for that, I can help you afterwards, but really we need to make sure that we're getting good quality sleep, okay? Energy conservation. This is my bread and butter. I love this area. And essentially the whole concept of this is to find ways to clip coupons to make my budget go a little further, and then find ways to deposit money into my bank account. And that whole concept is called energy conservation, okay? So everything you need and you want to do during a day costs you a certain amount of money or a certain amount of energy. It can be dependent on what your lab values look like. It can be dependent on literally the season of life you are in, whether it's fall, winter, spring, but also too, like your personal season of life, what's happening for you personally. And then exercise. It's a great return on investment. Yes, it's in your budget, but the dividends you're going to get is really going to help your bank account. So another really great thing to kind of talk about from a banking perspective. So we'll work through all of those things. And really, how can we work smarter, not harder? Can you fold the laundry sitting as opposed to standing at the washer or the dryer, right? Stress management is huge. Who has stress in their life? All of us, right? Adulting, chronic stress. Finding ways to help manage your stress, identifying coping strategies, really helpful in managing all of those things. Attention strategies. I told you earlier I'm a little squirrely, which is probably why I'm doing well bouncing between all of these things right now. In reality, don't do multiple things at a time. Only do one thing at a time. And break down a larger task into a smaller task. That's why there's a picture of candy on here. I usually say no more king size candy bars when it comes to projects, only fun size candy bars. So when you're talking about traveling, if you need to get ready to travel to Italy, there's a lot of steps to get ready for that. Check in for your airfare, figure out what to pack, get someone to house sit to watch the dogs and water the plants. Who's going to take you to and from the airport, all of that, right? It's a lot to keep in the back of your brain to figure out what you've done and when do you need to do it. So you're going to itemize that out on a list because that helps your memory, but it also helps your focus. And then you can cross those things off as you go, but it's also a built-in rest break for you physically and cognitively. So then you're a little bit more structured and focused, okay? Memory strategies. I had a friend over here who I think had to step out, but she gave me some good ones. Like the pill box, that's an external memory strategy. A to-do list is an external memory strategy. A calendar, alarms, right? Things can be very low tech, which is like the pill box or an alarm, or something as high tech as an AirTag or a tile keychain. I actually had a patient who was consistently losing her car in the parking garage, so she got an AirTag and we put that in her car, and then she always had her phone on her and she could pull it up so she always knew where her car was, right? So it's like a high tech external memory strategy to offload your brain so you're not like, oh, I parked on green 3C north, but I have to go up on the left staircase, not the right. Like that's a lot to remember. And yes, a little dramatic, but still, that's a lot to remember. So then you're not going to remember the talks here today because you're too worried about figuring out where your car is when you need to leave, right? So the AirTag, a great way to help offload the brain. We have some internal memory strategies. Truthfully, I don't like them too much because they're historically not as reliable and much more energy seeking. Like they take more energy than they are helpful. So we'll kind of skip that one. Environmental modifications are really important, right? So set up your environment for success. Reduce your distractions. Noise isn't great, okay? Visually too, right? Our eyes, though, need a place to rest, and I don't think people realize that. So when you're having a workstation, whether it's literally on a computer and having all of your files saved on a desktop with no strategic process at all behind that, not a great move. You're going to spend all of your time trying to find it, right? But it also could be for some of my gentlemen who like to tinker or who have a workbench. Have that in some kind of organized chaos that works, right? You don't want everything everywhere because then you're not going to be able to see what you need. It can also increase your risk of injury because you don't know where things are. You might trip, all of that stuff. So make sure that your eyes and your ears both have a place to rest. It'll help promote your attention. This is really where OT comes in. We're going to talk your way through certain things to kind of help you have more success with it, right? So this one's a little bit more overarching, but for the sake of time, I'll skip that one, okay? And then the bread and butter, as we kind of like highlighted together and did an activity already. So cognitive retraining is where I have the best job in the world. All of my coworkers, and I have a couple sitting in the room, so thanks guys, always get really jealous. They're like, man, you get to play games all day. And I was like, yes, I do, thank you. But there's a lot of skill behind it. And they're activities that really challenge your attention. They might challenge your memory. They might challenge your processing speed. They might challenge your strategic processing. There's a lot of things that happen inside your brain that you don't realize that you're doing because you've been doing it for so long, okay? And then until it doesn't work anymore, but you don't know what you're doing, so you don't know how to fix it. That's why you come to someone like me. So games are really great. Crafts, learning a new hobby, all of those things are kind of dual purpose for me because you're starting to do something you enjoy again, because you should. We need to have access to hobbies and leisure activities, but it's also a really great way to recruit your brain, okay? And so I really like my, again, kind of cheesy slide here. If you don't use it, you're going to lose it. Who's heard that as an older adult, like physically? You better walk, you better exercise, you better lift, you better do those stairs, because if you don't, you're not going to be able to use it. You're not going to do it again. It's the same thing for your brain. So despite the like cancer timeline of when I notice brain changes, I also notice it a lot with women going through menopause, okay? It's a dip in hormones. There's usually a little bit of a dip in thinking. But then I also usually notice it quite a bit in people who retire, okay? The biggest reason behind that perspective is that the strategies that you've utilized for at least the last 30 years of your life to manage family, kids, spouses, work things, plus personal things, you're no longer using them because you're like, oh, I got all the time in the world. And that's true. You do. You've earned that. But you're probably wasting a fair bit of that time because you're no longer using the strategies that you used to. Okay. And then the other thing is that work-related tasks really make your brain have to function at a higher level. And that's a lot of cognitive retraining, but it's not always the fun kind of cognitive retraining, unless if you have my job. So that's where kind of coming in and having things like game night. There's a lot of research that is actually supporting the use of dancing for cognitive retraining, which is kind of cool. Number one, it's going to help you physically because of your strength and your endurance, as well as your balance, because dancing really does require some balance. The other piece behind that is social participation, that connection with your dance partner or the dance class. Whether we want to admit it or not, we all need kind of that social connection and that community. It's really beneficial for us in multiple ways. And then finally, it's really great for your brain because if you're like me and you really can't dance, you have to learn new steps and remember a routine. So there's a lot behind this dancing concept, okay? But a great game night is one of the best ways you can kind of implement that. And some of my favorite games right now are like Taco Cat Goat Cheese Pizza. That's probably my top one right now. And it's very quick and easy. So my last brain activity I'll give you in like 30 seconds, and it's something that I kind of do with my patients, and I'll modify it for today. But what I'm gonna do is I'm gonna need you guys to say a word that begins with the letter that is gonna appear on the screen. And I don't know if my friend over there can click that link here in a second, but while you're giving me that letter that begins on the screen, it has to belong to the category fall or like autumn, okay? Does that make sense? Any questions? Okay, can you hit the link for me? Hopefully the link works. I tried it, we'll see. I may be young, but technology is not my friend. All right, spin the wheel. Da, 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 da. K, give me a word that starts with the letter K that belongs in the fall category. I'll give it to you. Great. That's a great game. Great one. Can you spin it again? Kit Kat. It was Kit Kat. I see there's candy on the table. Whoever gets the words first can shout it out. W. Weather. I'll give it to you. Okay. What witches? I like witches a little better. Sorry. Sorry, weather folks. Okay, let's do one more just for the sake of time. It better not be K again. I'm gonna trump it and say J. It's J.
Yeah.
It's J. Give me a word for J. What is it? Jack-o'-lantern. Anyone have any other ones? Jelly beans. Have you ever played Bean Boozled? Jelly beans are ruined for me now. No? Okay. So that's everything. So this is just like a very high level, very quick thing that is talking about some of that brain fog. Does anyone have any questions for me in our last 4 minutes? I apologize for going quick. Yeah.
Wait 1 second. So
I used to work as a nurse.
Yeah.
And there was always this problem. I did a lot of teaching, trying to motivate people so they would understand what they needed to do, but there was just a lack of motivation. And so we did this intervention or this what did they call it? What was it called? Therapeutic
Intervention
yeah.
or motivational
And so we
interviewing.
would say, could we talk about your diet today on this visit?
Yeah.
And they might say, I just have so much on my mind and the kids are just tearing everything up and I just can't really focus. And so that would just go on. And if they never said, yeah, this would be a good time, or, oh, I've been meaning to talk to you about that. There was just, and we felt like we just kept dealing with the same thing over and over and over. How do you motivate? And even in my own life, I feel like I have all these excuses of why I don't go back to my walking, or why do I keep eating that ice cream every night? I call it one of my 4 food groups. You know,
Call you Buddy the Elf.
that link to motivating somebody to do some of these great things that we all know we need to do.
That it's a hard question, right?
Yeah.
And that's where I really think supportive services like myself. So at the James, we really do have a robust supportive care team, whether it's counseling versus PT, OT, speech therapy, dietitians, right? And we also have like patient case managers, right? There's a lot of different interventions. And I think the earlier you can kind of get people connected to that, the better, because part of our job is helping to hold you accountable. And also part of our job as a medical professional is to know what is to come for you and make sure that we're asking the right questions and be like, no, you really should do this. Sometimes too, though, I have the hard conversations with my patients where I'm like, I led the horse to water, you ultimately have to drink, right? And so it's hard, but I think that that's where you just have to try to find the way to connect to that person and then find what works best for them. It is. That's also too where having like things like this and finding an accountability partner can be really helpful. Kind of that support group concept is really helpful. That's why you're more likely to go to an exercise class versus to just go to the gym by yourself. Any other questions? Okay, I know it was quick. Thank you guys for following my brain. That's a skill in itself.
Thank you, Kristen. That was really helpful for me personally and other people as well. So I think that we're running a little bit behind, and so if you need to take a break, please go ahead and step out and take a break, and then I will find Marcos. Yeah. Okay, cool. Okay. Okay.
Trying to sync up. Okay, welcome back. So it's my pleasure to be able to introduce a good friend and colleague, Dr. Zainab El-Bugdadli. Dr. El-Bugdadli is a nationally recognized infectious disease specialist with a focus on infections in cancer and transplant patients specifically. She earned her medical degree from Alexandria University in Egypt and completed her infectious disease fellowship at MD Anderson Cancer Center in 2016. Dr. El-Bugdadli has served on the faculty at OSU for 9 years, and during her tenure, she represented the James Cancer Hospital in national organizations. This included the NCCN Guidelines Committee for the Infectious Complications, and for cancer-related infections, and the ASTCT Transplant Infectious Disease Steering Committee. She is now joining Atrium Health Levine Cancer Institute, and we welcome her back. Thank you.
Right. So today I will focus on infectious consideration for cancer patients. Have no disclosures. In this talk, I will go over some key principles on how to diagnose infections, risk stratification, and we'll go over the overlap between infection and GVHD. And then we'll highlight some real life scenarios through which we'll go through steps on good lifestyle, how to be healthy. Okay, so we'll start with the talk of the town and how AI, artificial intelligence, has been integrated into our life. And this is not just a regular cartoon that I found online, but actually real time. So patients have been asking these questions. So that's why I thought of bringing this as a break noise for our talk today. One thing I would like always to highlight, even to trainees, that common infections are common. So cancer patients, GVHD patients are still at the same risk as everyone else, but with their immune deficient system, they are at risk for certain opportunistic infections. And every patient is different. So we need to individualize care, and that means taking into consideration different factors. That's why the textbook is not the case in these patients. Meaning, if you pop up certain information on Google and look it up and give you something, that doesn't mean that that's the right answer, because there are a lot of other things that play a role here in the diagnosis of infection. And a lot of our patients may have very serious infections, and they look great, smiling, cracking jokes. So we need to pay attention to certain details when we are taking history and examining different aspects of their body. And one thing, since everyone have access to their chart now, a positive test does not necessarily mean an active infection, because it can bring a lot of anxiety. So always discuss with your physician, and don't jump to Dr. Google or ChatGPT, but take your time. With that, I'm not against this. We actually need the artificial intelligence to help us do our work faster, more efficient, to help improve care. Okay, now let's look at the different factors that contribute to infections in GVHD patients. So as you can see here, they are all integrating, and one can affect the other. So it's a very important relationship. So when we talk about different factors, host factors, the patient himself, their age, having other diseases, having diabetes, have other autoimmune disorders, all of these things can add more to your overall health status. If you are on other medications that can, other than your GVHD medication, can have some side effects that can interact with your medicine. So these are important factors. Other things is, what is the status of your disease? Are you in remission? You're different than someone who's in relapse, who's requiring higher immune suppression. The environment you live in, your prior exposure to certain infections. We acquire a lot of things when we are young, and they remain quiet, but then under immune suppression, they can reactivate. So these are factors that are important to consider. The external factors, your hobbies, your travel, other things that you can be exposed to and put you at risk. So how these things act together, and how can it increase risk for infection? So I'll go over certain organs, since GVHD can affect every organ, even if it's subtle and you don't have a GVHD of that organ. The transplant process itself can impact certain aspects of your body. So we'll start with the respiratory system. We all have this ciliary mucus all over our airway, starting from the nose, the trachea, the bronchus. And the functionality of these cilia are very important. It's like vacuuming the floor, right? So you can imagine, in those who have impairment of these, they will have stagnation of their mucus, which will invite bacteria and fungi to flourish. So these patients tend to be at risk for recurrent bacterial infection. How can we prevent that? Behavior modifications. So big gathering where people are sick, wearing mask when you know you have to be around someone who's sick, or in crowds, things like that. We give patients antimicrobial prophylaxis. Other important cell line is the neutrophil function. And this is very important to prevent invasive fungal infection. Steroids, which is a drug always used a lot in GVHD, can impact your neutrophilic function and can put you at risk for invasive mold infection. If you are in relapse and have prolonged neutropenia, that's also another factor for fungal infection. That's why a lot of these patients require being on antifungal prophylaxis as a prevention. And we will talk about behavioral modification for fungal infection. The third line of defense is what we call as the humoral immunity, which is your antibody response to infections. And the medical term for that is what we call as hypogammaglobulinemia. And for those who are aware of the IVIG, that's why these patients receive ready-made immunoglobulin, a pool, to help them providing this antibody response to various infections. That's why these patients tend to have prolonged viral infections, what we call as shedding, right? You test them, they're always positive for rhinovirus, for influenza, or for COVID several times, despite feeling better, and sometimes they have prolonged course, and this is because of the lack of humoral immunity. The fourth line of defense is your T cell, your macrophages, is what we call as the cellular immunity. And you need that to fight viral infections because viruses tend to be inside the cell, live inside the cells. And I listed some of the viruses like the herpetic viruses, some fungal infections, and some atypical bacteria like Legionella and Listeria that are present in our food and water. Our patients can be at risk for that. How can we avoid that? Antiviral prophylaxis. A lot of patients are on acyclovir or letermovir to prevent reactivation of these viruses. Vaccination when it's appropriate. The last thing, and not least, is what we call as functional asplenia. So the spleen is an organ on the left side of your body that help you fight certain bacterial infection, specifically the pneumococcal pneumonia, the streptococcal pneumonia, and Haemophilus influenza. So these patients can be at risk for recurrent bacterial infection, including sinusitis, bronchitis, tracheitis, or even recurrent pneumonias. How to prevent that? We give prophylaxis, we give vaccination, and again, behavioral modification, right? Being away from someone who's sick. Okay, so every time we encounter, or the transplanters encounter a new GVHD case, there is always the question, is there an infection that's triggered the acute attack of GVHD or a flare of GVHD? And this is something we encounter a lot, the chicken or the egg, which one have led to the other? And sometimes we found them concomitantly. For example, for GI or the gastrointestinal, those who have new onset diarrhea. This could be infectious diarrhea caused by bacteria or viruses, like C. inviac, and that's why when they do the endoscopy and they biopsy, they are not only looking for GVHD, they are also looking for infections. Other things that we see common and can be overlooked is the nausea. A lot of our patients, they take a long list of medications and they have the nausea and they feel some heartburn. It could be just simple, but at the same time, it could be a serious infection like HSV, like a resistant type of candida that's causing these symptoms. Or it could be GVHD. So you see how it can be difficult to differentiate the two, and we need to have an open mindset when we evaluate these cases. Other things, the liver. A lot of our patients receive medication that can have side effects of elevation of liver enzymes, like the antifungals, and at the same time, you can have GVHD of the liver. So which is which? So we always work together with the transplanter, the hematologist, to see this out. Lung, another common syndromes is the organizing pneumonia and bronchiolitis obliterans, and there will be a talk about that later today. These are non-infectious causes, but they can mimic infection, and patients tend to require a lot of antibiotic courses, and they are not getting better because it's not an infection. Brain. As Kristen was talking about the brain fogging and also the side effect of certain medications like tacrolimus, in some cases we see something called PRES, posterior reversible encephalopathy syndrome, which can be induced by tacrolimus, but at the same time, the same symptoms can happen with an infection. That's why when they start looking at the drug levels and then the patient continues to do worse and there is no improvement, then we need to think about, okay, maybe we are dealing with an infection. Maybe the patient needs a lumbar puncture. Let's do some testing for that. And last and not least is the medications. Medication side effects are very important. The effect of medication on each other is very important because some of the medication that I prescribe can affect the transplanter medication. So every time I start something, I talk to them so they can adjust their tacrolimus. The letermovir can impact antifungal as well. Also understanding that certain medications, those who take Jakafi, for example, if we stop it abruptly, the patient can manifest with a syndrome that looks like a flu-like, sepsis-like. So understanding these syndromes that can masquerade as infection, but it's not, it's important for us as we tease out these cases. With that being said, that shows you that our model to protect our patients is like a Swiss roll. A Swiss cheese model, multiple layers to prevent all these holes in their immune system and all the problems. But there is nothing perfect, correct? We don't have vaccines for every single infection. We cannot give the patient all the antimicrobial agents. So it's a hybrid of everything. And what's most important is staying vigilant for any abnormal manifestations that are seen by the patients or someone and their physicians. And we work as a team for that. Now let's look at some data on infection after transplant. So the lower pie chart is for adults. Is that the pointer? Yeah. So the lower pie chart here is for adults. And as you can see, that infection, the gray is the second most common cause of death within the first 100 days, and it dropped to a third after 100 days. And that shows the importance of prevention of infection in these patients. So the key thing here is to work as a team, and this is what we do with the hematologist, with the pulmonologist, with the dermatologist to tease out all these complex issues when working with these patients. All right, now we'll go through some lifestyle scenarios. And for those who have their phone, or maybe because we have small crowd here, maybe you can raise your hand. We'll go through some questions. I'll start with the fungus infections, okay? It's fungus among us. It lives everywhere. When patients say, how I got this? I'm like, well, there is more fungus than us. There is more pathogen than us. It's in the soil, it's in the air, the sand, so you can easily get exposed. But when your cilia doesn't function well, right? Doesn't get rid of it. When your immune cells are not functioning, these ubiquitous pathogens can impact your immune system. So I listed here some of the activities that can be at risk. And I know some of us enjoy doing these type of things, gardening, excavations. It can put you at risk for different type of fungus like aspergillus, which is a mold, histoplasma, which is an endemic fungus that's in the soil of the Ohio Valley. I listed here the map of the US, and there are different other endemic mycosis like blastococci here in the West. And as an infectious disease doctor, I always ask my patients where they have traveled. And they say, well, I traveled 10 years ago, or why this is relevant. No, it's relevant because the fungal spore can be in your body, dormant, but then where you are getting a flare, you're receiving steroids, it can reactivate. So it's important for us to have this consideration when we evaluate patients. Other occupational risk, I have listed them here. Marijuana. A lot of people use marijuana, and we always tell them that the smoking and vaporization is the most dangerous form. Why? Because you can inhale the spores of the plant, and that can go to your sinuses, can go to your lungs, and can cause issues. So patients ask, okay, so what should I do? So the ones that are cooked or baked, so not through inhalation. I'm not promoting this, but I'm just saying for those who are interested in this. Okay. So I always say that the fungus is the silent invader. because you don't know it until it's there. And it can be very very obscure, like it's very hard to diagnose sometimes, and it needs a lot of awareness from the patient to just feel, I don't feel right. There is something keep pushing in my nose. I don't know, something in my mouth. I put here some pictures. The upper ones are the trachea and the bronchus, and they have white patches. And this is what we call as tracheobronchial aspergillosis, where the aspergillus actually cause infection of these areas. If the infection continues to go down, it will go to your lung, and then it can start causing small nodule like this. If you do a regular X-ray, you may not even see it. But the patient will tell you, I have this drying cough, or every time I take a deep breath, it kind of hurts here. It's odd, but I thought it was muscular, but then it's kind of persistent. We always examine the mouth of our patients. So we also tell them to look into to their mouth as well, because infection can look like a small black spot that can expand. This can be a fungus too. So this is one of my patients. I thought he's going to be here today, but this is not his picture. He was able to overcome tracheobronchial aspergillosis and exercising, and was able to resume. So the good news is we have good antifungal treatment for these infections, but again, there are some different types of molds that are difficult to treat or they are resistant, so we need to be careful as we deal with these infection. All right, what does this mean? Should you quit your hobbies? And I was putting this slide, and I was thinking about one of my patients who like to do gardening. So I can tell patients to drop their hobbies, right? So if you want to do your gardening, what should you be wearing? If you want to do mulching, which require a lot of anything that requires to have a lot of air or heavy exposure to air droplets, this is a high-risk condition for fungal infection. So which mask, either use your phone or you can just raise your hand. What would be the right mask if you want to go gardening and do some construction activities? Yes. Thank you, the N95. All right. Yes. So the cloth mask is not going to help you, very loose. Surgical mask, maybe if you're doing some planting in a pot or something, but if you're doing something that has a lot of dusting, then you should be wearing something with a good fit. The K95 is good, but the optimal is the N95. All right, and don't forget to wear your gloves and footwear to protect yourself, because of the healing, you can introduce some fungal spores. A little prick can introduce certain fungi and certain bacteria as well. So it's very important to be aware. Okay, now let's move to some other activities, water activities. We live in Ohio. We have some patients who drink from well water, so that's kind of risky because of the parasites and bacteria that live in it. That doesn't mean everyone would get an infection if they drink from it, but it's high risk. They say, well, I have a filter, but the filter does not filter everything. Other activities, those who like to do kayaking or rafting, anything that causes a lot of water splashes can cause some infections like leptospirosis. I don't want to go through all the infections, but it can be risky. Okay, now let's go through another real-life scenario. So you have your 6-month-old daughter or granddaughter, for the audience here, who received the Rota vaccine. It's an oral vaccine. Then the baby developed some diarrhea. Should you change the baby's diaper? Yes, it's totally safe. Anyone for that? Okay, yes, but only with gloves. Avoid diaper changing. Okay. It depends on how liquid the stools are. Look at that one. All right. Why? Why? So that's the correct answer. Anyone knows why? Huh? So the rotavirus vaccine is a live vaccine. It's actually a live virus. So even if you wash your hands, maybe you accidentally can introduce it to yourself and can get the norovirus infection itself because it's a virus. So we usually advise that they should, and it can be shed up to 4 weeks. So keep that in mind. All right, so now we'll talk about vaccination tips for caregivers. So obviously take your scheduled vaccine as appropriate because you are protecting your household contact who has GVHD compromised, right? I always tell patients and their family, always tell them you are caring and or you live with someone who has an immune compromised disease. And this is one reason, right, about the vaccine, so the physician can give you specific instructions. Other vaccines, like the influenza vaccine, someone's like, oh, I don't like shots. Can you give me something nasal? Yeah, get the active virus, right? And you can spread it actually to other people. To regular individual, it may not be a problem, but for someone who's immunocompromised, it might be a problem. So knowing these things are important. Similarly, if someone receives chickenpox, a child, and then they have a mild rash, stay away from them because they are contagious. And I like to put this photo for those who have seen this movie. Anyone have seen this movie? Yeah, the Benjamin Button. Yeah, so he was born as a, also this is how I always say about the transplant patient. They are like the newborns, their immune system is naive because they lost all their prior immunity to all the vaccination they received as children. Okay, how about vaccination for our GVHD patients? Usually it started 3 to 6 months, and usually the transplant clinics take care of that. Your physician will let you know when is the proper timing. There is no strict timing that you have to take it today. What if you are in a flare of GVHD? Then it's going to be shifted. If you are on high immune suppression, then it's not the optimal time because you may not mount a good response. What if you receive it and then you start having flare of GVHD? We're going to stop the vaccination series. So there's all these players that we take into consideration when we give vaccines to these patients. Live attenuated vaccine should not be given to transplant patients until after 2 years when they're completely free of any immune suppression because of the risk of true infection. Now, we'll move to animal lovers, right? Those who have pets at home, which one and which we can't have. So the ones here carry a higher risk. And don't laugh about it. I have patients who have reptiles, who have turtles, and weird snakes. So these type of pets can carry a lot of exotic, atypical infections that we can't even test for. We don't know what they are, and for those that we know, we can test for, like salmonella and other can be serious in patients. So we always tell them to avoid this type of animals. We spoke about the fungi, and also the birds can carry certain atypical infection. For those who have cats, we always say to avoid changing the litter box of the cats because they can carry toxoplasma. They can also carry some bacterial infections. Those who have kitten, Bartonella through the fleas can be a source of infection. And the bites and licking wounds, and I have patients who actually have animal bacteria, not human bacteria. And I tell my patient, do you have dogs? Do they sleep with you in the bed? It's like, how do you know? I'm like, yeah, I put camera in your home to make sure you're staying safe. So yes, you can actually acquire infection from animals with pathogens that are strictly for animals, not for humans. So I try to tell my patients to have a little bit of a distance with their animals. Yes, I'm not telling you get rid of your pet, but having this close contact in the bed at night and inhaling all these bacteria that they have. The dog doesn't have to be sick. So just be mindful of these things. Those who have fish tanks. The water is clean, everything looks great, but never put your hand inside because you can get a common infection, we call it Mycobacterium marinum, that can get through your small fissures and wounds in your hands. So always wear gloves. Dogs. Kennel cough. Have you heard of kennel cough? Yeah. Yep. So Bordetella bronchiceptica is a common infection that is strictly related to dogs, and human can get it. Oh,
Can you repeat the question?
yes, yeah, okay. So she has my hand microphone.
What do you do when you visit people that have these present in their homes?
Well, I would say be cautious, right? A little bit of a pet is not going to cause you a problem. It's not like inhaling a spores. If you stay away from it, you should be okay. You go home, you wash your hands, and you can tell from looking at the environment of the place how hygienic they are. But so I think it shouldn't be a problem. Yeah. Okay. You visited your friend who has the dog. Okay. And they told you, oh, don't worry, he just got this vaccine, the intranasal bordetella vaccine to prevent the kennel cough. Is it safe for you to cuddle the dog? Continue cuddling. The vaccine is fine, should be protecting the animal. Anybody for that? Second, let the dog sleep in its bed, but wash your hands more often. Or avoid close contact for a few days. Or revaccinate the dog with the other form of the vaccine. So the answer is avoid contact. Reason is intranasal vaccine, it's a live vaccine. That's why it's important to let the vet know that you are a transplant patient. So they have another form of that vaccine that is intramuscular, that's inactivated, which is safer for you. Okay? Because we see this quite often. Okay, so here's some safety guidelines for pet ownership. Always get a healthy animal. What's the best timing? Obviously, down the road, 6, 12 months. Obviously, if you're high immune suppression, then you should avoid that. Go for regular checkup. Tell your vet, and as you saw in this scenario, how it's important to have this information. And keep your animals indoors so they don't bring any infection to your home. Okay, one more real life scenario. You're doing good, you wanna travel, you wanna enjoy life, you're going on a hiking trip. They told you there are certain vaccines you need to take. Which of the following you should not be taking? Yellow fever vaccine, would you take that too? Or no? The question says actually why you should not receive. Do not receive hepatitis A vaccine, typhoid vaccine, influenza vaccine. Yeah, why? You're so good. Thank you. Yes, it's a live vaccine. Actually, these countries, it's mandatory for you to fill the form, so they may not let you get into the country unless you have a certificate that say that you are vaccinated. And if you are not vaccinated, you need this form to be filled by the physician that you are an exempt from vaccination. This is a website I like to share with patients. That's the QR code for it, the CDC website. As you can see here, you can search the country, and it tells you what you should be looking for, what type of infections, if they have any epidemics or anything going on, what type of vaccine, things like that. And you can reach out to your primary care doctor or your infection doctor. They can give you information. West Nile virus and other vector-borne infections that can be transmitted via mosquitoes and ticks. So I always tell patients that they need to look at this website, and then it has very good instructions on how to prevent that. Covering your body, wearing long sleeves, and using DIT for the for your body, but then for the clothes that you wear, you use the permethrin. So the permethrin treated protected clothes are very helpful, and they can last up to 6 weeks or 6 washes. This is different from the off spray because that's DEET. This is different, this permethrin. You can also buy it over the counter, and they have instructions on how to use it. So to summarize, enjoy life, right? enjoy life, but be cautious of the things that can put you at risk. Medicine has advanced. We have better diagnostic tools for infections, but we still are limited in treatment and also diagnosing certain exotic infections. Medicine again advanced, right? We have more immune suppressant drugs, but they come also with side effects. So we need to watch out for that. And I always tell our patient that they are our second set of eyes. So if you see something, say something. We are here to help. And with that, I will pause here. I'd like to thank our patients who are always a good example of resilience, their caregivers as well. And I made this acronym, GO GVHD. It's a growth, vitality, hope, and determination. So thank you for being a good role model for us. So with that, I'll take questions.
That's great. If you have a question, I'll move the microphone for our virtual attendees. Just one moment.
A COVID vaccine.
What about it exactly?
Well, I haven't had one. I've had the flu vaccine, but my doctor was unsure when I last asked. What do you think?
So there have been some changes regarding the COVID vaccine recommendations, as you've been hearing in the news. The vaccines are important to prevent infections, but the severity of COVID vaccine have been less than what it used to be in the pandemic. And there are many factors, as I mentioned, that goes into the vaccination, right? If you're having a flare or you had a previous side effect, etc., your doctor may tell you, let's take one vaccine at a time. So it's more of a shared decision making type of thing. But if someone who is known to get really bad COVID and then they have issues in their lungs, you don't want them to get another extra virus that can make them worse. But if someone is stable and off immune suppression and they feel like, well, I don't want to take the vaccine, then you can, okay. Again, it's more of a shared decision-making, risk versus benefits.
What are your thoughts on going on a cruise, on the cruise ships, staying there?
Well, there's always risk, right? Because you wouldn't know until you hear it on the TV with the norovirus outbreak or etc. or rotavirus. So it's risk, benefit, and there is no way for you to know before going on the trip because the food that they have there is no other. It's not like you're gonna skip the food. But if there's one case, right, then you should stop eating from the ship. But yeah, sorry, it's a risk. You can't eliminate it.
Question is, are there medications you can take beforehand?
So for the viruses, there is none. Yeah, for the viruses, there is none. Yep.
There are several questions online. Any other questions in the room? Okay. How long are the infection precautions advised until off all immunosuppressants or forever post-transplant? If someone is positive on gut biopsy, that's the second question. Go ahead for the first one. So how long are infection precautions advised until off immunosuppression or forever?
So usually it has, okay, so it's more intense when you are on immune suppression and it become more relaxed as you are off the immune suppression. This is how I would say it. And that's a question you can always ask your doctor. But sometimes patients are off immune suppression, but their bone marrow and their immune system has not fully recovered. So even if you are not on anything, you're still at risk. So it's more of a conversation.
So case by case.
Case by case, yeah.
Definitely. Okay. The next question is, if someone is positive on gut biopsy for CMV, will the serum CMV always be positive too?
Okay, very good question. This is something we always teach the trainees. No, you can have a negative blood test for the virus. This is one of the viruses. What it causes what we call as a compartmental disease, where it's only in the organ but it's negative in the blood. So that's why even if it's negative in the blood, we have to go for a scope to rule it out.
And next question is, should immunocompromised GVHD patients have a booster RSV vaccination after their initial vaccination? And if so, when?
So the RSV vaccine is only one-time vaccine, and we always like to give it when the patient is off immune suppression, since insurance may give you issues with approving another vaccine because it lasts for so long. So yeah. We have to give it at the optimal time.
Great. Any other questions for Dr. Elbow-Dodley? Thank you very much.
Yeah, thank you.
Oh, wait, there's one more question that just popped up, Dr. Elbow-Dodley. Are there precautions that should be taken moving houseplants back indoors?
Yes. So with the house plants, if it's close to your face, you're inhaling it. You don't have to see the spores. You're inhaling it. So I would say wear a mask. I would say no indoor plants. I have a patient few months ago who had a plant fungus. She was inhaling it because they used to have an indoor plant. So I would be careful with that. Also wearing gloves while you're handling them.
Is this for how long after transplant do you advise that?
I would say for 6 to 12 months, and it goes longer if you are on immune suppression.
Okay, great. Oh, and okay, but what if never off immunosuppression? Should you still get RSV vaccination? This is going back to the RSV vaccine question, sorry.
Yes, I would say if you are at high risk, if you have lung issues, or if you are around kids or etc., you can take the RSV vaccine.
So personally, we advise RSV vaccination for all patients post-transplant, particularly with GVHD, and especially those with a history of lung GVHD or lung pathology. So again, case-by-case basis, but similar to the influenza vaccine, I think
Correct.
the
Yeah,
vaccine is
correct.
for
Yeah,
getting patients
vaccines
protection.
protects you from the severe form of the infection. It may not prevent it completely, but it will prevent the severe form.
Okay, I don't think there are any
Right,
additional questions
active
at this
group. I
time.
like it. Thank you.
Thank you.
Yeah.
Okay, I'll hand the microphone over to Dr. Biletic. So let's see, to introduce our next speaker.
Okay, thank you. So it's my great pleasure to introduce the next speaker. It's Dr. Kulim Lee. The title is Oral Care Essentials After Transplant. So we know that oral cavity is site of most common complications after transplant. And Dr. Lee is an assistant professor in the Division of Pediatric Dentistry at the Ohio State University College of Dentistry and the pediatric dentist at Nationwide Children's Hospital. She is a board-certified pediatric dentist and an NIH-funded clinical researcher. She earned her Doctor of Dental Medicine degree and a PhD in microbiology at the University of Florida. She later completed her Master's of Science and residency in pediatric dentistry at the Ohio State University, Nationwide Children's Hospital, and her current research examines bacterial, genetic, genomics, and microbial ecology as they relate to oral and systemic health, with a particular focus on the oral microbiome in pediatric patients undergoing hematopoietic stem cell transplantation. So we look forward to hearing about your work. Thank you.
Still morning, so good morning, everyone. Thank you for the opportunity to talk to you guys about a very important aspect of post-transplant care, which is the oral care essentials. I'm actually giving this talk on behalf of Dr. Jacqueline Mace from the NIH. She was supposed to be here, but obviously can't be here due to federal travel restrictions. So it's a huge honor, to be here in her place to give this talk. This is sort of the objectives, what I want to cover today in our talk. And again, Dr. Jacqueline Mays shared her slides with me, so I'm very thankful of that as well. We will discuss the general oral care after transplant, what that looks like. We'll discuss some oral complications that you might be experiencing after transplant that is related to graft versus host disease and some that are not. We will discuss the symptoms that you could experience when you're experiencing oral chronic graft versus host disease, as well as discuss different types of it and discuss different treatment modalities that's available at this time. a quick roadmap of our talk today. The very first key message is take care of your mouth. Sounds very simple, but it is foundational. And we'll go over sort of what aspects that could entail, including one, how to find a dentist, who to look for, what to ask, importance of oral cancer screenings. And we will discuss about some of the complications that you might experience, again, as non-GVHD symptoms, and specifically that you will experience as you have GVHD symptoms. Sometimes they present differently in the mouth. We'll go over that in detail. So before we get started, I kind of wanted to discuss a little about the oral anatomy and dental terminology that I'll be using throughout the presentation today. So the oral cavity of the mouth is really a gateway to the entire body. It's a site in the body that we often see early signs of systemic diseases or systemic conditions, and also the immune function. It's more than just the teeth. We have the gingiva, the gums that cover the teeth. We also have this soft tissue lining, this moist tissue that surrounds all around the mouth, and that is the mucosa. There are tissues that lines inside of the cheeks bilaterally, and those we call buccal mucosa. Now, like I said, the oral cavity is a very unique part of the body. It's the only part of the body that's openly in constant contact with the external environment. So naturally, there's a lot of natural defenses that's available, and there's a lot of immune function already built in. There are certain areas that have active immune system. One, like the tonsillar regions. This has, the tonsils have a lot of immune function, as well as the sublingual aspect. So underneath the tongue is where we also see a lot of the immune responses. Now, we have three major salivary glands in our mouth. We have one parotid gland, we have the submandibular, we have the sublingual glands. These three are the major glands that produces that watery saliva in your mouth. But beyond that, we have maybe over 2,000 to 3,000 minor salivary glands that are equally important. They also produce some amount of that saliva in your mouth. And they're particularly important because they reflect the state of the function of your major salivary glands, whether that's the immune state or the pathological state. The minor salivary glands are the ones that sort of reflect how your major salivary glands are functioning. Now, how should we take care of your mouth post-transplant? This is really very similar to how you should be taking care of your mouth pre-transplant. But there's going to be different elements because your mouth is going to feel different, and it's going to feel a little sensitive, post-transplant. Number one thing I like to emphasize to our patients is to use fluoride toothpaste. Now, your teeth is that the most outer layer of your teeth is composed of the enamel, which is the most hard mineralized tissue. As you're going through transplant and post-transplant, your teeth, that enamel layer might have been exposed to different environments. One, your diet might have changed to a more cariogenic diet, meaning you're eating more of the sugary, high source diets. I'm gonna close my eyes with all these sugary snacks that we have and the desk on the tables right now. Also, you might have been, with nausea, you might have been vomiting, and these teeth might have been more exposed to acidic environments. And common symptom we see is dry mouth. So your teeth might be in an environment that there's reduced salivary flow, and all of these really increases the risk of you getting dental decay or dental cavities. And so fluoride is the important molecule that really helps remineralize these softened parts of your teeth and these demineralized aspects of your teeth. So I recommend you guys using the fluoride toothpaste. Now, you might just have a sensitive mouth. You might all of a sudden not be able to tolerate the most common toothpaste that contains mint flavor. In those patients, I like to recommend using fruit flavored ones, or even children's toothpaste. These are a lot gentler to your tissues. You might have sensitive teeth now. Fluoride rinses or gels could be prescribed or provided. your dentist could provide you a higher fluoride-containing toothpaste called Prevident that could also be helpful in this controlling the sensitivity. And also, the flavor is a little gentler, so it oftentimes feel better on your mouth. We also have desensitizing toothpastes. There are several ones that are listed here, but Sensodyne is one that I like recommending to my patients because Sensodyne also does not contain SLS, which is sodium lauryl sulfate that causes that foaming agent in the toothpaste. So these foaming agents sometimes exacerbate that dry mouth sensation in your mouth. So this is something that I like to recommend in our patients that have dry mouth and also experience some teeth sensitivity. One important thing to note is that it takes a little bit for these to work. So you use it one day and then it's not like you'll see results immediately. So just give yourself a little bit more patience. If your teeth are extremely sensitive, you can get professional desensitizing treatment with your dentist. And this could be just as simple as getting additional fluoride in office, or this goes all the way up to providing even like laser therapies to help control this sensitivity. If you have limited joint mobility, electric toothbrushes are something that we recommend. The electric toothbrushes have smaller heads of the toothbrush, so it's easier to reach some of the areas that are far back. One thing I love recommending my patients, and I'm a pediatric dentist, but I did practice as a general dentist before, so I did see a lot of my older patients. So for these patients, I like to recommend even children toothbrushes or even taller toothbrushes. You'll notice that the heads are way much smaller and the bristles are much softer. So these are very, very helpful to reach the far back areas or even areas that are harder to reach with like a big toothbrush. So the key message here is that you want to use what works for you. And these little tweaks will help you better maintain your oral health. Flossing is very important for maintaining your gum health. I think this is, it could be complicated because some transplant centers ask you to refrain from flossing, but they don't really tell you when you can resume back, with the normal flossing. And generally speaking, typically, if you have stabilized with your transplant, and unless there's like a specific medical reason, most of the time you are okay to continue flossing. These little strips of flossing are difficult to use, and myself included. So water picks or electric flossers are another tools that you could use. And then I love these little Christmas tree flossers. If you have more space between your teeth, these are great to sort of go and reach those areas to get that debris out for your gum health. Now, finding a dentist or having a dental home is very important. At Nationwide Children's Hospital, I see a lot of patients pre-transplant and post-transplant, but I'm not their routine dentist. And this might have been you. And so it's really important that you have a dentist that's local, that you can go for just preventative work as well as just regular cleanings. Tell them that you're a transplant survivor. This is an important detail that should be shared so they can tailor their care towards you. If they look a little confused and that they don't really seem familiar with the transplant process or how to manage, then that's okay. Like, it's okay to look for another dentist. When you go to a dentist, it does happen. When you go to your dentist, you want to show them, all these lesions, bumps, lumps, color changes, textures in your mouth that you see. The previous speaker had mentioned that you yourself is the best second eye outside of the physician or the dentist, etc. So if you notice anything, show them to your dentist. And usually these lesions should heal within 3 weeks, but there is an asterisk there because this timeline unfortunately doesn't include patients that have graft versus host disease. Do you ask for an oral cancer screening? This is particularly important for patients that have had oral chronic graft versus host disease, and we will discuss this in a little bit. Now, Again, not every dentist might be able to appreciate your medical needs or your medical history. So if you feel like you're going to dentists that really don't have a good understanding of this, then it's totally fine to look for another dentist. You can start that conversation just by asking, do you have experience in treating complex medical patients? Typically, university dental clinics as well as hospital dental clinics have a lot of providers that are more experience in managing these layered medical histories. And oftentimes, if you do have oral chronic graft versus host disease, you might need some specialty treatment, and oral surgeons, oral pathologists, or even oral medicine specialists are the ones that I would definitely see because they have, been seeing this for a longer time. Getting an oral cancer screening yearly is extremely important. Now, this is particularly important in this population, and especially if you have a history of oral chronic graft versus host disease. The period of time where that risk is higher is 5 to 10 years post-transplant. And the site in the mouth that we more commonly see these presentations is around the tongue, on the lateral borders of the tongue, so the sides part of the tongues. This is a photo that was shared by Dr. Mays, and it's a patient that had this lesion, and this is a presentation that they noticed this, 2 to 3 weeks prior to that photo, and this was 5 years post-transplant, and that ended up being oral cancer that needed a lot of treatment. So, one, I don't want you to start worrying about this, and this is something that you worry every night. The risk of getting oral cancer in general is very low, but this yearly screening is therefore important. So, I keep an eye on it, you keep an eye on it. It's something that we just continuously monitor. Oh, one thing I was going to mention is that this oral cancer screenings are very simple, very non-invasive. Your dentist should be looking at your mouth very thoroughly, and it might already be part of their routine exam. They might take a gauze, move your tongue around, try to look in the back of the throat, palpate around your jaws, underneath the chin. That is all part of that routine screening. But if they're not doing it, ask for it. So, were you going to? Yes, looking at everything. Yes, visually. Right. So the oral post-transplant complications generally follow a trend, but there is some good overlap. So you might experience mucositis, dry mouth, or thrush the early part of your transplant, and then the overlap period usually results from drug-induced complications from your systemic dose of methotrexate or sirolimus. It could be also secondary to viral infections that have reactivated or flared up, and that's usually from herpes simplex virus and human papillomavirus. And then late transplant period, those oral complications might be due to the chronic GVHD, and then the symptoms will go into a little bit more detail later on. And also, some of the complications could be secondary to the oral cancer that we just talked about. Now, let's discuss some non-GVHD post-transplant complications. First and foremost, the loss or change in taste. So this can be something that could be related to the chemotherapeutic agents you received in the past. It could be something that appears suddenly, and it's like how your mouth perceives taste and texture as well. So things that you used to eat and enjoy, like meat, you no longer want it because it just tastes and then it feels different in your mouth. You can be experiencing radiation-induced dry mouth, and this can also appear very suddenly, which we will discuss in a little bit. You might also have medication-related oral ulcers or lesions that will be needed to be monitored and then discussed with your dentist and your physician. And when you're post-transplant, you go through an immunocompromised state. You're constantly, fighting various infections, and a lot of the infections are caused by normal, organisms that are normally part of your body, and it wouldn't have caused a problem if you weren't immunocompromised. And those come from, it could be just fungal infections, you could have thrush, you could have bacterial or viral infections, and some of the cold sores that appear during this time period would be from that herpes simplex virus reactivation, which we'll talk about right now. So herpes simplex virus reactivation is quite common. there is an acute onset and it's quite painful. Typically, they present around the lips as well as inside of the mouth. This photo is perfect because it shows this roof of that blister before it gets unroofed. And when it gets unroofed, that's when you see that blister that's extremely painful. If we suspect HSV infection, then we do want to take a swab to send it for DNA testing. And at the same time, we might do other viral DNA testings as well. Typically, the way we manage this is with a magic mouthwash or lidobenalox that contains Maalox, Benadryl, and lidocaine. And, it's palliative. It'll just help you sort of control that pain for a little bit. And then sometimes systemic antivirals are indicated. Oral thrush is a very common complication in patients post-transplant. This is when that candida overgrows in your mouth, and that could be various reasons. You're immunocompromised, you've been on chronic use of antibiotics. It could also be because you're on topical or systemic steroids. Some steroid inhalers like fluticasone could also be a cause of you developing thrush. So if you use that inhaler, you don't rinse your mouth, then you could develop thrush. These can appear different ways. One, you can have this hairy presentation. This is the pseudomembranous candidiasis form. You can also have this redness, this erythematous form. Now, this is a photo of a patient that developed pseudomembranous candidiasis in the back of the throat. Management typically is topical antifungals like clotrimazole that we usually allow dissolve in the top of the tongue. And this is really important as that close contact with those tissues and letting that time with that antifungal is critical. And sometimes if this can be added to your systemic antifungal prophylaxis if you're already on antifungal therapy. Sometimes you will get these ulcers from your medications, and that is the sirolimus-induced oral stomatitis. This occurs when you have excess circulating levels of mTOR inhibitors, and these levels are very high systemically, causes mucosal toxicity. And it may form these painful aphthous-like ulcers with the well-demarcated borders, as well as this focal erythema. Now, management, it looks definitely, different than the viral induced ulcers. The management here typically is topical steroids using magic mouthwash, and then again, working with your physician. If these lesions are really bad, then, we would want to communicate with your physician and talk about possibly adjusting your sirolimus dose. We sort of talked about the non-GVHD related oral complications, and now let's talk a little about the symptoms that you might experience as you have oral chronic GVHD. The symptoms really vary widely, but one of the most common ones is dry mouth. This can present very suddenly. You were okay one day, and then the next day, your mouth just feels extremely dry. You might realize that you need to drink more water to just swallow your food. You can start forming these blisters on the roof of your mouth called mucoceles. These mucoceles are these immune cell infiltrates that sort of block the opening of the salivary glands. Your salivary glands continue to produce saliva, and this sort of gets underneath that surface and then forms this fluid-filled vesicles or lesions. And I'll show you some photos later, but those are some of the presentations that we might see when we do our thorough exam. You can see these red and white patches in your mouth that do not scrape off. You can start seeing some mouth ulcers that are related to GVHD, and we'll discuss this in a little bit too. You can start seeing these white lines on the cheek lining of other parts of the mucosa called lichenoid striations or lichenoid patterns. That is a classic sign of oral chronic GVHD. And in addition to dry mouth, one common symptom that patients report is oral sensitivity, and that is to spicy foods, citrus fruits, lemons, acidic foods that you were able to tolerate before, but now you're extremely sensitive towards it. And just understanding, some of these symptoms that could arise, these could be these trigger signs and early signs of the onset of oral chronic GVHD. Now, going in a little bit detail of the oral manifestations of chronic GVHD, and it could be in 3 domains. The first domain is the mucosal lesions. You might see this red and white striations, that lichenoid pattern that we just talked about. You can have these hyperkeratotic lesion presentations as well. Again, the white and red lines that could be all around, the palate, the gingiva, and the tongue as well. And these are the mucoceles that I just talked about that present to the roof of the mouth. You can see some of the areas are red and looks irritated. You can have these ulcers that form as part of GVHD. And surprisingly, these ulcers, they're not really painful if you're not eating or drinking or touching it. And oftentimes, the redness, this lichenoid striations or these ulcers are the first signs that the patients themselves notice because it starts just looking different. But these aren't really the first signs that develop. You might start seeing some patchy hyperkeratotic tongues. And so that is the mucosal domain. We also have the sclerosis, the perioral sclerosis domain, which is the limited opening. And this could be directly related to your temporomandibular joints, or it could be related just due to that sclerotic tissue around your mouth. And then the third domain is the salivary gland dysfunction, which we'll discuss in the next slide. But that is, of course, when when you start having dry mouth, and then you have all these like oral sensitivities symptoms as well. Now, salivary glands can be a target of chronic graft versus host disease, and this is when the immune cells start infiltrating the salivary glands, particularly the acinar cells that produces saliva in your salivary glands. It's important to know that you might not have any mucosal lesions, but still have salivary gland involvement. And one of the reasons why dry mouth is particularly important to notice and for us to ask about is due to your increased risk of cavities. So a lot of the patients with xerostomia or dry mouth, they experience this smooth surface caries. And this is a common pattern of caries that we see in patients that kind of sip on pop or juice all day. And unfortunately, and even other medical conditions like Sjogren's syndrome, these patients have dry mouth and present with similar smooth surface decay patterns. This is a slide just to sort of highlight it's a data from the NIH cohort showing the 3 different domains that we just talked about: oral mucosal lesions that you can experience, salivary dysfunction, limited mouth opening. And this is to show that all of these different domains or presentations can happen independent of each other. So you might have oral mucosal lesion presentation, but have no salivary dysfunction, or vice versa. And it's really important that we understand this as, the pathologic mechanisms is different, one, and so then the treatment regimen should be different. So to diagnose chronic graft versus host, number 1 is if you see that lichen planus changes, that is a hallmark of that clinically we can say that you are having some symptoms of chronic GVHD. And especially if you have other symptoms or other presentations such as dry mouth, mucoceles, ulcerations, mucosal atrophy. And if possible, when possible, we do want a biopsy to have that more confirmed diagnosis. And so we can rule out other possible diagnoses, oral infections, drug reactions, or new cancers that we kind of talked about earlier. These are some images I just wanted to share to show some of the diagnostic features of oral GVHD. So these are some of the lichenoid lesions that we talked about. It'll be these white lines, red lines around your buccal mucosa, as well as this is the inner part of your lips, your gingiva there. You can also have different presentation of in the palate. You can clearly see that patients just develop differently. So they could have these striations, but some could just have that erythema, that redness on the roof of the mouth. And some patients could present with these mucoceles, but not everyone. Your tongue could present differently as you experience oral chronic GVHD. So you might have the atrophy of the papillas that are important for tasting in your tongue. You can see that glossy presentation, that shiny presentation, and that is called atrophic glossitis. We might have these hyperkeratotic patchy areas of your tongue, and then another, patchy tuft keratosis presentation of the tongue. And it's important to note that, you and your physician as well, when they're looking at it, this is not oral thrush. It kind of looks like it, but if you look at it clear and, do additional exam, we know that it looks like it, but it's not candidiasis. Pseudomembranous ulcerations is a common feature and a distinct feature in patients with oral GVHD. These ulcerations can form underneath the tongue, around in the buccal mucosa that we saw in the earlier photo too, and as well as around the lips. Now, diagnosing salivary gland or asking about your salivary gland function is very important. So your dentist should be asking you about, when you kind of present with these symptoms, asking about, is your mouth suddenly drier? Is it progressively drier? Do you have difficulty eating, drinking food without addition of water? Are you taking some medication that could even exacerbate this? So for example, you're on antidepressants, and this could actually exacerbate the dry symptom that you already have secondary to GVHD. So it's an important discussion to have. And if you did get total body radiation or a more targeted radiation, like around the head and neck area, then your risk of salivary gland dysfunction is high, of course. But an important note is that a biopsy is actually needed to confirm or have a formal diagnosis of this, and typically they would do this in the minor salivary glands. So let's talk about the preventative measures. And one of the things I wanted to, that we like to emphasize is that there is no level of dental hygiene that would have prevented you from getting oral GVHD. So this is not your fault at all. But good oral hygiene can help reduce some of the complications that you might experience as you go through those GVHD symptoms. Good brushing twice a day, that's always the answer when the dentist asks you. That's important. And also getting your routine dental cleanings, that's very important. And whether you need antibiotic prophylaxis, depending on your medical status. But so getting that routine exam and cleaning and that oral cancer screening is really important. And there are some therapies for different stages of GVHD symptom presentation. So if you experienced mucositis early on in your transplant process, one of the ones that we talk about is cryotherapy, which is essentially having or holding ice chips in your mouth, or other cold therapy that really helps alleviate some of these pain symptoms. Sometimes we offer or we recommend our patients to use supersaturated calcium phosphate rinses, and this is to help that wound healing process. So that is something that we sometimes recommend for our patients, and of course, adequate pain control is important. One of the things that we don't have on this slide is red light therapy, which is photobiomodulation therapy. I'm sure you guys have heard of it at some point. A lot of the dermatology, maybe on TV or social media, you see advertisements of it, like bathe your whole body or your face with, get younger, all that stuff. But anyways, it actually really works. It is part of the supportive oral care for oral mucositis. For adult populations, it's been since it's at least 2019 or so when they updated that guideline. But it really helps help with that pain and the healing of mucositis. So that is something that you can explore, and there are handheld devices that you could purchase, but we have to make sure it provides the right power, right wavelength. But most of the hospitals, or a lot of the hospitals, are trying to implement it in their practice to help these mucositis symptoms. So topical therapy for GVHD patients, the first line is dexamethasone oral rinses. This is actually the first line therapy that's available. The response rate is like 30 to 60%. And, you might think that it's not really high, but it's actually good considering that there is not a well-established second-line therapy. This oral dexamethasone oral rinse is really important. The most important part of it is giving an adequate time in your mouth, and that you hold it in your mouth with that recommended time. You put a timer. Make sure that it is touching your tissues before you spit it out, and that is the one way that's going to be most effective in helping you with some of these GVHD symptoms. If you have lichen planus-like changes or oral ulcers, like discussed, steroid rinses are helpful. If you are sensitive towards steroids, then calcineurin inhibitors like tacrolimus rinses can also be used. If you have an isolated ulcer in your mouth, and we know those are going to be painful, sometimes topical steroid gels or tacrolimus gels are used, and we also saw. I'm also seeing that you can also do an intralesional injection of triamcinolone, and this is something that the rheumatologists use a lot to help with joint pain. This is something that I probably wouldn't do on my kiddos, but for more of the adult patients I could tolerate. I have heard that it's very effective when it's directly applied to that ulcer bed. Aids for dry mouth. One of the things that we recommend is sugar-free gums and candies. And again, I want to emphasize sugar-free aspect of it. Oftentimes, these candies or gums have xylitol, which is the alcohol-based sugar that a lot of the the carcinogenic bacteria in the mouth cannot metabolize. So so you don't get cavities. So make sure it's a sugar-free gum if you're going to suck on it all day. Lemon flavors can stimulate saliva. So this is something, to kind of help you with your dry mouth symptoms. Obviously, keeping yourself well hydrated is important, frequent sips of water. And there are some lubricating rinses that we recommend, and one of them is BioTE. And these have these, it lubricates it. It's pretty basic, and it also helps with maintaining that hydration aspect of it. And it's something you have to find what works best for you, and then working with your dentist to figure out what could help you in the long run. There are prescriptions that could be provided in patients with dry mouth, and some of the medications, pilocarpine or Salogen and Evozac is listed here. Now, this only works if you have at least some functioning salivary producing cells in your salivary glands. And it does take quite a bit of time to show full effect. But important to note is this might not be medically indicated or medically appropriate for you. So again, discussing this with your dentist and then your physician who's managing your GVHD symptoms will be very important. I'm going to go back to fluoride. Fluoride is critical for your oral health and then preventing the decay. So check your toothpaste if it has fluoride. Again, the fluoride rebuilds that dental enamel, especially those areas that have softened and demineralized. So make sure you check that it does contain fluoride. And some of the modern toothpaste contain active hydroxyapatites that's helped rebuild the tooth enamel. So that's something that you can explore as well. But I don't think there is good long-term large clinical trials that have looked at how effective hydroxyapatite containing toothpaste is in compared to fluoride containing toothpaste. Remember, the reason why fluoride is important is because when you have dry mouth, your risk of decay increases, and especially because, saliva that buffers that acid and basic capacity in your mouth, and then it also returns that calcium to that damaged enamel. So if you have less saliva, your teeth are less protected, so you gotta protect it extra by using fluoride toothpaste. When you have that sclerotic perioral or like limited opening presentation, some gentle intraoral, extraoral massages could be helpful. And especially doing this, with a physical therapist or occupational therapist could be helpful. And they might develop a program, using stacked tongue depressors and then adding another tongue depressor gradually to help you increase that opening. So that physical therapy can really help. And in some very, very severe cases, they do provide perioral steroid injections or do surgical interventions as well. Now, as we kind of talked about everything, oral chronic GVHD is very persistent. It's still a very difficult complication that affects quality of life of a lot of our transplant patients. And this is just to show some of these treatment modalities that have been tested in randomized controlled trials. A lot of these are topical steroid rinses. Response rates vary from low 50s to 70s. And the effectiveness kind of varies to everyone. And one important thing is that it does not cure the symptoms, right? And so the point of this slide is to kind of show that more clinical trials are necessary to develop more of those targeted therapies to help with some of these symptoms that the patients might experience. There is one clinical trial that's open in Madison, Wisconsin. So if you're from there, maybe you want to check it out. This is a different kind of approach where they use a autotransplantation of your mesenchymal stromal cells from the bone marrow and directly deliver it to your salivary glands and they're looking at whether that could improve the dry mouth symptoms. So I'm going to look into, Dr. Mays wanted me to share this with you guys. So if you have any questions, you can definitely contact her as well. So the last thing I wanted to, or second to last thing I wanted to end with is another study that is ongoing right now, which is using red light therapy to help oral GVHD symptoms. And this trial specifically is looking at the efficacy and safety, testing the efficacy and safety of this red light therapy. And like I said, this has been extensively used in controlling and alleviating some symptoms and healing symptoms of oral mucositis. The way this works is it's a non-invasive light therapy, and at a specific wavelength, it could really help increase healing, reduce inflammation, and reduce pain. And this is not invasive, sorry. So I'm particularly excited about this because I've been starting to see more and more children, and older children that are experiencing some chronic GVHD symptoms. And we are already trying to implement the red light therapy for mucositis management. And it just seems so easy, to provide, especially if it's going to help with that pain control and that inflammation. So something I would definitely, I'm looking forward to the results, and hopefully something that you guys could follow too. So key points, see your dentist regularly, especially after your transplant has stabilized. I will admit a lot of the dental part of your whole medical list, the dental is usually on the end of the list. And oftentimes when I see my patients back, it's been like 5 years post-transplant and they have a full mouth decay or they're just having all these symptoms. It's easy to kind of forget about it because there's a lot of things on your list, but just at least doing the routine regular cleanings could really help prevent a lot of these complications or help notice it so we can help manage it early on. And of course, take care of your mouth by brushing and flossing every day. All right. Thank you so much for your time. I work very closely with children undergoing hematopoietic cell transplant and when they're admitted, and they are a very, very dear part of my just me in general. They've taught me so much, and their resilience is amazing, and I just learned from them a lot in general. And the parents are amazing, and they are surviving. They are becoming older, and so I'm kind of on the other end right now, talking to you guys, but I really appreciate this opportunity to be here and share this passion with you guys all. So I'm happy to take any questions. Yes.
You went over some medical aids
Yeah.
for graft versus host or graft versus host. Will those help improve the food sensitivities at all? Is that known?
That's a good question. I don't know about food sensitivity. Usually, it's more like with lichenoid lesion presentations that we see, and then and that could present with the food sensitivity and or just isolated. So that's something I could ask Dr. Mays about as well. In the long run, could it help like the taste perception or the sensitivity towards food? But the taste, I will say, what we see is that perception of or changes in taste can gradually improve on its own. So hopefully, you don't need topical steroids for that.
Thank you.
Any questions? Okay. Okay, so we're gonna break for lunch. Thank you so much. And so I believe that lunch is out there and being served, and then we'll go back over to the other side for the keynote presentation and panel discussions, and I think that's it for that part. Thank you. Okay.
So good. I don't know if you've been here again, but definitely come back.
That's right. So this is my plan. So I was just like, this is going to be like this, I guess, staple place for me. I love everything.
Awesome.
Yeah. Right?
Yeah.
Yeah. Very good.
Okay. There you are.
Oh, awesome.
Whenever you're ready. Okay, so it's on. Here's your dancer.
Oh.
Next that. I give this to you.
I get this.
Meredith, extra mic. She's got one too.
Beautiful. Thank you.
Mhm.
Going well?
Thanks for filling this. So I never really so did I? Yeah. Every.
Nice to meet you.
Well, thank you, Mark. Now, nice to meet you too. So, back to me work. I started looking at it.
You think I should start or you?
It's been a confirmation.
Okay, I think we're gonna get started if everyone's ready.
So this.
I guess we have a few more trickling in. No one's listening. No one's listening. All right, everybody, I think we're gonna get started. My name is Betty Hamilton. I'm one of the transplant physicians at the Cleveland Clinic. I have the real pleasure of introducing our next speaker. Before I introduce her, I am reminding everyone to fill out your feedback forms. We really value your thoughts and how we can make this symposium better and better every year. So thank you for filling that out. So at the last lunch and panel, I think we all heard a lot about the importance of rehab and how important it is to have rehab doctors as part of our care of chronic graft versus host disease. So it's my real pleasure to introduce Dr. Eileen Slavin. She's one of my colleagues from the Cleveland Clinic. She's a physical medicine and rehab doctor. She's specially trained in oncology rehabilitation. She graduated from Ohio University Heritage College of Osteopathic Medicine, completed residency at Larkin Community Hospital in Florida. Clinically, Dr. Slavin treats patients who have a cancer diagnosis and also those surviving with cancer who have challenges with pain, functional impairment, and quality of life concerns as they're recovering from chemo, surgery, and/or radiation. We are thrilled that she joined the Cleveland Clinic in 2023 after finishing her fellowship at Georgetown University Hospital. And Dr. Slavin and I have been working on trying to collaborate more so that we can better treat our transplant patients before, during, after, especially those who are with chronic graft versus host disease. So without further ado, Dr. Slavin.
Wonderful. Can you hear me? Okay, perfect. So thank you so much to
so that the virtual people can hear.
Yeah.
That people, there's a microphone, so we can pass it for people to participate.
Oh, perfect. Okay, awesome. Well, thank you so much, Dr. Hamilton. Thank you to Meredith, the foundation, all the supporters, patients, caregivers, for this invitation to speak today. This is really great. All right, let's get started. I have no financial disclosures. And this is our sort of blueprint for the day. So as a PM&R doctor, I would be remiss if I didn't include some component of physical activity and to discuss some related subtopics. Some of these things we've also touched on throughout the day in the scientific track and probably in the patient track as well. And then the second part of our conversation will be a multidisciplinary rehab evaluation, stressing its importance and going over some strategies that are very specific to the allotransplant population and for patients, of course, who are struggling with chronic graft versus host disease. So without further ado, let's jump right in. All righty. So this is and has been a challenge because everyone is coming from a different experience in terms of what their transplant was like, what their disease is, what is their treatment situation, how severe are the after effects that they've had to deal with from cancer. But essentially, the American College of Sports Medicine has a roundtable discussion, first convened in 2018. And essentially, there are experts from AZ who come together to try to provide some exercise guidelines for cancer survivors, including our transplant survivors, of course. So there's overall pretty good evidence that exercise helps with a lot of things. I won't read this to you. But one of their main, points initially was more research is needed to advance the level of specificity available in the exercise oncology literature to serve a broader range of cancer types and stages. So again, just the focus on, okay, we need the right intervention at the right time for the right person, and we're all different, and we've all had a different experience through this process. The overwhelming consensus, though, of course, is to avoid inactivity. Okay, so you don't actually have to raise your hands, but just think about it. So how many of you have felt weak and fatigued since transplant? That maybe your transplant was a couple weeks ago, a couple months ago, maybe it's been years, maybe even decades at this point. But how many of you, internally, you want to raise your hand, feel weak and fatigued in some way? How many of you feel that your endurance has been affected? You used to run a lot, you used to hike, you used to cross-country ski, you went on international trips, you went and traveled to see family and friends all over the country, and now you feel like maybe you could do a tenth of what you could do before in terms of day-to-day functioning physical activity. which leads into the next point. Are your day-to-day activities different since your transplant? Are there certain things you avoid? Are there certain things you try not to do? You try to conserve energy. Do you have to conserve energy to make it through the day? So these are all really important questions that we've tried to incorporate into research. I'm still working on some of these things too myself, but it can be hard to sort of quantify because we know these things exist. They just exist on a continuum or a spectrum for each person. Okay, so this is just to say you were not alone, right? I'm sure all of our survivors in the room could have raised their hand at least once for one of these questions that I posed to you. Another fun infographic from ACSM's initiative. This is our Exercise as Medicine Moving Through Cancer. One of their many research waves and community waves of trying to figure out how to target exercise for our survivors of any cancer type head to toe. So you can see, I know you can't read all the specifics here in terms of aerobic and resistance exercise. We'll get into that in a second, but there's really strong evidence that exercise is great for cancer-related fatigue. That's huge. That is a huge, huge problem. It's been discussed already today. I don't think it's discussed enough, to be honest with you. Exercise improves health-related quality of life, physical functioning, anxiety, and depression. I don't know that we've touched on mood today in the other room, but that's also a really, really big problem, right? When your life is suddenly different and changed and will never be quite the same because of a cancer journey. I call it a cancer experience because it's sort of an ongoing situation, right? It doesn't just stop when you survive a transplant and keep going on with your life, but I don't think we talk about that enough too. Some of the psychosocial impacts. So that's, of course, involved in how often you move, your motivation to move, how well you think you can move, all of those things. Okay. So current guidelines as they stand today, we say about 150 minutes of exercise per week of moderate aerobic exercise. So moderate intensity. Obviously, moderate intensity for one person is very different from another person. Again, this has been a hard thing to quantify. What is low, what is medium, what is intense? That probably depends on how active you were before you got sick. And that depends, of course, on what has happened since and with your treatment. And then resistance exercise is 2 times per week. And that will come into play a little bit later in this presentation too when we talk about the effects of steroids. Okay, so give me some examples. All right, so maybe you used to be a marathon runner, maybe you used to hike 8 or 10 miles at a time, and now things are a little bit different, and so you need to think of, okay, well, what's my new normal sort of exercise regimen going to be? What are some things that I can do that would also keep me safe? Because you might have some neuropathy, you might be really tired, you might be sometimes dizzy or lightheaded. You might have some other medical comorbidity. So I've listed some examples. Of course, there could be more, but a stationary bike can be really nice. A foot peddler, if you're not quite there yet. Walking as much as you feel comfortable counts, okay? Aqua therapy can be really nice as long as your skin is intact, you have some supervision. Also group exercise classes. And I realize that that can be challenging if you're worried about infection, especially because we're coming into cold and flu season. But they can also be very motivating. The other people who are exercising. We have organizations in the Cleveland area, like I'll just plug the Gathering Place or Stewart's Caring Place, but people in those exercise classes have also had a cancer diagnosis. So it's not about being the fastest or the best person. It's really just about finding your community and finding your people like you are today. So that can be very motivating for you too. And then in terms of resistance exercises, so I usually say about 2 sets of 8 to 10 reps, 2 times per week. And it doesn't necessarily have to be heavy weight. We're not trying to be Olympic weightlifters here, but even, small bands, 3 to 5 pound weights, just the fact that you're doing something and you're doing some repetitions to build some muscle mass is really, really important, especially if you've been initiated on steroids or you're taking steroids long term. Okay, And this is one of my favorite parts. So this is a 30-second sit to stand. And I'll demonstrate it for you. If you feel comfortable doing one yourself, you can. So essentially it is, the picture is not totally accurate, but essentially it's being seated in a chair and then crossing your arms in front of you and then being able to stand up and sit down all the way without holding on to anything. So the purpose of doing that would be to build quad strength, glute strength, core strength. Those are all muscles that are of course affected by steroids. So steroids like to affect the muscles that are closest to the rest of our body, our trunk. So that would be like shoulder muscles, quads, glutes. And of course that involves things like getting up out of a chair, being able to walk up and down stairs, right? These are normal human activities that you need to be able to do every day. So doing this sit to stand at home, especially if you're unsure, someone could be nearby, just to spot you, but it's a really nice thing that you can do to build up some muscle strength. And there's a little chart on the right-hand side of the screen. So that is the CDC range for quote unquote normal patients. So essentially someone who has not necessarily had a cancer diagnosis is included in this schema. I use this to help motivate my patients in clinic because sometimes patients will say, oh my gosh, I couldn't really do this. And then they end up actually doing quite a few more than they think that they could. And then I'll say, okay, well, compared to the, general population, whatever that might look like, you're not too far off, or actually you're right where you need to be for your age group. So it can be motivating. You don't currently have a standard guideline for functional outcomes for oncology patients and oncology survivors. Something that we're working on, some of my colleagues around the country are working on. So it's a little bit skewed, but just some good information. So if everyone wants to try to do one of these, if you can and if you feel comfortable, if not, it's okay, you can stay seated. So I know you can't see me sitting with this chair where it is right now. So essentially crossing your arms over your chest and your back is all the way to the back of the chair. So you're going to stand all the way up and then sit all the way down with your back to the chair. You can do another one if you feel comfortable. So
they can still see us, but they can
all the way up, all the way down. So that might have felt easy, that might have felt hard. If you're trying to time this, how many can you do in about 30 seconds? So the first one or two, even for patients who have not had a transplant, feel okay, but if I try to do as many as I can in 30 seconds, I even feel winded. So I can't even imagine what it would feel like to have had a transplant or cancer diagnosis and all the treatments too. But this is something really nice that you can work on. I have a colleague at Memorial Sloan Kettering that has patients journal this. So they actually have a chart and day by day, as many of these sets as they can do without feeling sick or without feeling too tired. And then you can track your progress over time, which is really nice. And it takes a while to build muscle too. So be patient. Alrighty, and there's some initiatives too. I just wanted to mention this really briefly. Some patients will ask me, well, do I need to go to physical therapy? Do I need occupational therapy? I can help you, with that decision if, you were to see me or someone who does what I do across the country in clinic. But we have colleagues who are working on really nice algorithms to decide who can do exercise alone, who should be supervised, who should start with a physical or occupational therapist before engaging on a strict exercise regimen just for safety purposes. The exceeds algorithm. And then again, before you embark on, a really intense exercise journey, you want to be. So do you have heart disease? Do you have high blood pressure? Do you have neuropathy in your feet? Do you have foot drops? Some of these things, right, might affect your tolerance to exercise and your ability to participate. Do you have fragile bones? Do you have bone pain, joint pain? We'll talk about that in a couple minutes. Do you have a history of balance issues or falls? Because if you've been falling a lot, it might not be a good idea to just jump right into something. You'll want to likely meet with someone like me or a physical therapist to make sure that we can safely build up your tolerance to exercise before you would do something a little bit more intensive.
Okay, and then some topics we'll hit on really quickly, and then we'll dive into the more specific things for graft versus host disease. But these are also really important and worth mentioning because what we do in rehabilitation can affect all of these things and are important for us too. So steroid-induced myopathy, maybe you've heard those terms, maybe you haven't, but this is a major, major problem. I see this in, I don't know, probably 99% of my patients who have had a transplant and have had exposure to long-term steroids because of their chronic graft versus host disease. We don't always catch this soon enough. Some of that is because we have a really big system and there's only one of me right now at my institution, but this steroid-induced myopathy is muscle shrinking and muscle weakness that you experience as a result of being on steroids long-term. We're not really sure exactly why steroids do this or how they do this. There's also a lot of research currently on, okay, well, if we can identify that this is happening in a person, then how could we stop it right then and not just let this go on and on and on? We don't have a supplement. We don't have a magic pill right now, but there are a lot of people working on this too, which is super encouraging. And exercise is really, really important for combating this. So even in some animal models, we know that if mice exercise while being exposed to steroids, that their loss of muscle mass isn't quite as great as if they had not started on an exercise regimen or resistance training. So that's encouraging, and we can apply that to us as well. Sarcopenia, another complicated topic. So there are conferences just devoted to sarcopenia, like multi-day conferences. So this is a loss of lean body muscle mass, and this is attributed to aging. Again, we don't know why this happens completely, and many smart people are working on this, but malnutrition is a really important risk factor for this. So in the scientific track today, we had Dr. Shah talk a lot about the microbiome and the importance of really good nutrition. So I just want to hit that point home that that's really, really important. And I know it can be difficult if you feel nauseous, if food doesn't taste the same, if textures bother you, if you have oral graft versus host disease, right? It might be hard to swallow. It might be hard to open up your mouth wide enough to eat certain types of foods. So you can talk to a rehab medicine doctor like myself or speech therapy, dietetics. We can help you with these things to the best of our ability. Some risk factors for sarcopenia. So many of these things we can't control, correct? So you might have comorbidities. Obviously, aging is an ongoing process. There's mitochondrial dysfunction, satellite cell dysfunction. So those are, immune system functionings happening at a much smaller level that we don't have direct control over. But I did circle a couple of things. So inadequate diet, inactivity, inflammation. So that also goes back to diet and exercise, right? Reduces inflammation. One of my mentors from long ago, who actually is at the public health school here, where I met him, took some of his classes, always said that inflammation was the biggest problem and sort of the culprit for many health problems that we have today. And obesity, of course. So those are things that we at least can't control or have some impact over to help make us feel better, to help with this accelerated loss of muscle mass as we age. Okay, and then going back to malnutrition, so how can we help? Consultation with a dietitian is really nice. Getting adequate levels of omega-3s, vitamin C, D, creatinine, and antioxidants are really helpful for sarcopenia. I also mentioned protein supplementation too, so beta-hydroxymethylbutyrate was mentioned in the other track as well. And I have a slide on this too. So that is, it's technically a proprietary blend that Ensure and Live has. It's Abbott Labs. So I'm not advertising for them. I don't get royalties from them, but they actually do have a proprietary, I don't know if the word is trademark, but they do have this market cornered, and they're actually the only product on the market that can sell with this label, that they have beta hydroxymethylbutyrate available, but this is a really nice one for building muscle, and that's been studied in animal models and in people too. So anyways, just to throw it out there, it exists to help build muscle back. And then osteoporosis, this is very common after transplant. This is why your medical oncologist might have you doing DEXA scans at certain points, pre and post transplant. So why does this happen? Well, the preparative regimens that you're exposed to, premature menopause for women, weight loss, medications used to prevent and treat graft versus host disease, right? All of the above can contribute to this osteoporosis. How do we fight back as much as possible with this? So diet, weight-bearing exercise, and making sure that you're having good conversations with rehabilitation, oncology, and also rheumatology if you're a good candidate for some of those medications that help build back bone mass. And then finally, some safety considerations. This might be more specific to peri-transplant situation, but I just wanted to include this. One of my colleagues who's was at Memorial Sloan, she's at Northwell now in New York, but she and some of our other colleagues published on this. So if your platelet count is low, if your white count is low, right, if your hemoglobin is sort of teetering around 8 or so, what makes sense in terms of movement and exercise, right? Because you wouldn't want to have a situation where you might fall and you have low platelets, right? And then you start bleeding. So, or if your hemoglobin is low and you don't have enough energy and you feel lightheaded, should you really be exercising, that sort of a thing. So just to, not to memorize these numbers, but just to put it out there that we do have some ranges in our purview for what types of exercises might be appropriate. And when I'm counseling patients one-on-one, I'll look at their labs and I'll look at their trends and sort of say, okay, your platelets are coming up slowly, but I wouldn't be doing X, Y, and Z right now at home just for your safety because I don't want you to take 10 steps back. Okay, and then the second part is the multidisciplinary rehab evaluation. So Dr. Harris was talking, of course, a lot about this. So essentially, I'm focusing in this part of the talk on sclerotic GVHD because this is the GVHD that affects fascial planes, muscles, tendons, ligaments, nerves. So these are all the rehab sort of things. In terms of big picture, we've been hearing this a lot, right? And we're all working towards making this better, but we have some limited data and efficacy for specific rehab interventions. But have no fear, we're going to talk about some things today. And really just to emphasize the importance of interdisciplinary care. So I listed PM&R, that's me, but PT, physical therapy, occupational therapy, speech, a dietitian, psychology and psychiatry can be great. Again, not always, mentioned up front, social work, palliative medicine, wound care. I don't have dermatology up here, but of course, and urology, gynecology, right? It takes a village to help people who are sick and trying to get back on their feet. So even if you have not maybe encountered some of these disciplines, if you think that you might need to see anyone listed here, or if after the talk you want me to explain the role of each of these members of the team, I can, but I think it's really important to be a good advocate and to advocate for yourself. In rehabilitation, I would say like 99% of what I do is collaboration with others. So I'm, sort of homegrown, used to this. But it's just really important to emphasize how important it is to have a collaborative, interdisciplinary team. So we'll talk first about fascial training. So 10 to 15% of patients who receive allotransplants develop sclerotic features of skin and deeper tissues. That was mentioned before. So in my perspective from rehabilitation, why is this important? Because you might have pain. You might have a loss of function, like a loss of range of motion of especially smaller joints. So if you have pain and if you have changes in function, then overall you're not as functional as you need to be. And that's the whole purpose of rehabilitation, right? Is to be able to do the things you want to do. So that's how this comes into my sort of view. So you might be familiar with the passive range of motion scale, right? So the more range of motion, the better. So I'll do this for all of my patients that I see just to get an initial sense of how you're doing. So these changes can happen so slowly and insidiously that I want to make sure if I'm following up with someone that I can see, do you have changes? Where are you losing range of motion? What might be a problem? And I listed, or I should say, I put this picture on here. So it says figure 6 because it's one of, I believe, maybe 22 or 24 images that I have. So Memorial Sloan Kettering has a really nice packet. And I didn't print it only because it would be many trees of paper to bring today. But there are, if you Google Memorial Sloan Kettering, fascial training, the PDF will pop up. And so essentially it's about 24 exercises that you can do on your own. I can't say that you should do them or could do them every day, but something you could do on a semi-regular basis just to make sure that you keep all your joints moving as much as possible. And if you notice that from week to week or month to month, you feel like the range of motion is changing in those joints, especially based on some of the exercises that I'm showing you today, that would be a reason to reach out, right? To say, hey, I did have better range with this movement, but now I'm not having as much range. And I don't know, can you just take a look at me and see what's going on? So that's a plug for MSK exercises. And this is a study I've listed. So this was actually a feasibility study. So there really aren't that many studies regarding loss of range of motion, that sort of thing in a rehab sense for graft versus host disease. I'm hoping I can change some of that. But this study, a small study in Germany, and they essentially took a small group of people undergoing allotransplant, and they found these patients and had them enroll. So 1 week before and 3 weeks after their transplant. And they essentially had 2 different exercises. I have a picture of this on the second page if it doesn't make sense. So they essentially, the first one is rolling a ball under their foot. So like rolling a ball under your feet, each foot. You have 2 feet for 30 to 60 seconds each, twice for each foot. And then from a standing position, taking what's called a fascia roll. We don't talk about these in the United States, but if you Google them, Denmark, Germany, other countries overseas have companies that sell these. They're just kind of like fancy looking, rolls, I guess. I mean, just like styrofoam. Kind of, yeah, but a little bit smaller and not textured. So basically, yeah, exactly, like a foam roller, but more of a specialized foam roller, and then putting that in between the patient's back and the wall and asking them to squat. And then doing that twice for 30 seconds each. And then they looked at back pain, back flexibility as measured by having the patient stand and flex forward, and then keeping their fingers straight. So in other words, like when you ask a kid, okay, bend over, touch your toes. So measuring the distance from the end of their fingertips to the floor. And also looking at muscle tone, quality of life, all of these things. So this is a picture of what they were doing, if this makes more sense. So rolling that ball under the foot and then doing this back exercise with squatting. And so it's a feasibility study. So it was really small. They don't have a ton of data, but they did find patients who did this had a reduction in back pain and improved back flexibility. So we don't necessarily, timing wise, intervention wise, for the right person, we don't have as much information right about what to do. But this was sort of interesting because it was saying, even if we don't have a lot of data, we know that patients don't have as much pain and they have a little bit more flexibility than they did prior to doing these exercises. So it's something, right? Every day we move the needle a little bit farther. The other question that I'll sometimes get, and I think this is worth mentioning too, is what about aggressive exercise? So what if I was the downhill, cross-country skier, and what if I am a person post-transplant who's made so much progress and I feel like actually I could do this every once in a blue moon? Should I be doing this? So I don't have as much data as I'd like, of course. But there was a study in Japan done in 2003, and it was regarding a young man, maybe 21, 22, who had received an allo transplant for a leukemia diagnosis and had done a 2-day downhill cross-country skiing, type of course in the mountains in Japan. And he ended up getting muscle pain, fevers, redness, right? Like some really kind of severe, graft versus host looking types of symptoms. He was admitted for a workup, and all of his blood work was elevated. So he almost looked like a patient who has rhabdomyolysis, so when muscles start to break down. He got IV fluids, they gave him steroids, and he instantly felt better. So then they thought, okay, well, then, retrospectively looking at it, this must have been some sort of musculoskeletal manifestation of graft versus host disease, especially if the steroids, made him feel better pretty quickly and normalized all of his labs too. So the patient then at some time point later resumed the same aggressive exercise and had the same result. So the conclusion was, even though it's hard to tell because other things might have been happening and we don't have biomarkers, we don't have a lot of good ways to figure out certain forms of graft versus host disease with the musculoskeletal system. They assumed it was probably from the aggressive exercise. So I try to make a point to tell patients that I want you to be as active as possible, but it's okay if you get back to maybe 60 to 70% of what you could do before. And you might have to sort of titrate your level of exercise to your tolerance and see, what kind of symptoms are you having. If it seems like you're getting muscle pains, you're getting cramps, you're getting, swelling, things like that, you might be overdoing it a little bit. Neuropathy, wanted to mention this, right, related to chemo, diabetes from steroid use, and others. Tacrolimus can also cause neuropathy. So how do we help with this? We basically treat the neuropathy. If you have painful symptoms, you can get, gabapentin, Lyrica, some of the neuropathic pain agents that we use. If you need bracing, if you have a foot drop, for example, we can give you a brace to prevent your foot from dropping, et cetera. So it depends on what you might need. We're just trying to make you as functional as possible. Joint pains are another interesting topic because most of the time this is muscle cramping. So tonic water, mustard packets, low-cal Gatorade can be really helpful here. Stretching as much as you can. But any, new or worsening symptoms would be good to discuss with your oncology team or with me, just to make sure that nothing else is going on. Because of course you could have had arthritis before your transplant, or you could have had an old injury that you knew you had right before transplant. So I basically say if anything feels new, different, worse in some way, that's worth mentioning because we might have to get some imaging, make sure you're not losing range of motion, et cetera. Okay, and then some supportive care modalities that have been mentioned. This is from an article from a few years ago from Spain. So adaptive devices or devices for ADLs, we sometimes say passive manipulation of joints like stretching, paraffin wax bath can be helpful, but you'd want to wear gloves, of course, doing that, or else you would hurt your skin. Some, authors and some practitioners have used manual lymphatic drainage, compression garments, pneumatic compression devices. So those are like pumps. Sometimes you see patients with lymphedema who have those. Orthotics and splinting are, of course, options too. I have a nice little chart. If you can't read this or if you want me to send you this, I definitely can. So it's just including some adaptation type devices, right? So some tools, splints, et cetera, that can be helpful for using the bathroom, cleaning, self-care, dressing, medication use, like a pill bottle opener is sometimes really nice. So yeah, that's there for you too. Yeah, this is my last slide. Yeah. And this is my last slide. So just to mention some other interventions that have been discussed. I put the potential part in red just because we don't have enough data for these. We talked about iontophoresis, phototherapy, extracorporeal shockwave therapy, and the roundtable panel discussion, so I won't mention those. Botox has also been mentioned. So in animal studies, we can see that this helps reduce fibrosis for like keloids and scars. So the concept might be applied also to graft versus host disease, although it's never been published before. And then adipose-derived stem cell therapy is also an option too. But of course, any of these therapies that are listed, you'd want to make sure that you talk to your oncologist before you embark on trying to use those. We can skip that. Okay, well, thank you so much for your time. My information's up there. There's the Cancer Answer phone line if you wanted to see me at Cleveland Clinic or if you had any additional questions. Shameless plug. But thank you so much.
Okay. Yeah. Hello. Okay. Yeah. Hang on. I'm coming to you, Chris. Oops, there go my glasses. That's how I lost the other pair.
It's going to get lost.
Thank you.
Hi, thank you for your talk. It was very comprehensive, but I do have a couple of questions and also kind of like a shameless plug because I know we have a lot of people from a lot of different places. Check out your local YMCAs for various exercise programs. I did at one point see like a Live Strong program, depending on if like a professional like our speaker today has recommended like you to do community exercise. Local YMCAs are usually a good place to check that stuff out. But I am curious about your institution or maybe within your own experience. Do you have anyone or anything for like specialization in myofascial mobilization as we're seeing a lot of the skin or scleroderma changes?
Yeah, so that's a really good question. I think that was the last slide that I skipped over. So thanks for bringing that up again. Yeah, so there are not guidelines on massage for patients who have sclerotic graft versus host disease. The problem being that if someone is using too much friction or force, it might actually worsen the sclerotic components. Manual lymphatic drainage is used for patient populations who have lymphedema, like maybe breast cancer related lymphedema, or patients who have GU or GYN cancers who might have had lymph nodes removed and have lower extremity swelling. So I would say if you wanted to try that, I mean, I would consult with someone first, right? You know, talk to me, talk to your oncologist, sort of a situation. But manual lymphatic drainage is very, very light touch. So
I am a CLT.
Oh,
yeah.
okay, perfect. Okay.
But
awesome.
I was also actually thinking more, I've done some like continuing education courses in myofascial mobilization. That is different than a manual lymphatic drainage massage. So I was just curious if you like had any background or like any kind of resources or anything like that. It just seems like it's kind of like a little bit of the wild, wild west. And you were talking a little bit about it. So I was just kind of trying to get more information from you.
Oh, yeah. Or, I mean, if you wanted to educate me just because I hadn't heard of that yet. Yeah, the myofascial mobilization or how that differs from massage.
Later.
Yeah, that would be
great. I was just, it's just some of the things you were saying. I was like, oh, that's like sparking a little thing in my brain. So yeah, we'll need to chat later.
Okay.
And then my other question for you is, regarding like neuropathy, do you guys have other options available that are not drug related or pharmacologically related? I know that that's usually one of the things I hear a lot about my patients is I just don't want to take another pill. Like, is there something else that you all have available?
Yeah, so it depends on what the neuropathy is. So if it's numbness or lack of sensation, we don't have a really good way to restore sensation. But if it's painful or annoying sensations, because some patients say, well, it's not necessarily hurting me, but it's just aggravating. It's like something it's like a buzzing almost that you feel that, yeah, exactly. That doesn't go away. So for that, acupuncture, could be useful if appropriate, of course, and if you cleared that with your oncologist. Besides acupuncture, of course, bracing is useful too, if you had a foot drop or, some considerations that way. We have scrambler therapy too, but that's an out of pocket. Yeah. That's an out of pocket cost though. So it's something to the tune of, I think it's $300 a session, and some patients do 10 treatments. So you could understand that for $3,000 for something that may or may not work is not an option for a lot of people. But that basically involves telling, your nervous system to reinterpret the messages to your brain that are painful or annoying. So that is also an option too.
Okay, I'm sorry. We have to end this session, and hope if there are more questions, you know where to find Eileen. And so what we're going to do now is get set up for the sound bath session. And so Leslie's going to pop in if she's not in here. Yeah, no. And then set some stuff up. So if you have to run to the bathroom, please do that. And then you can lay on the floor or sit in a chair. There will be mats available. Okay. Thank you, Eileen.
Thank you so much.
How are you, lady? Just finished sound. It's gonna start it. Yeah. Yeah. Okay. No, it's a very super special. What? I wouldn't know, but there is like an right, exactly. Exactly. And my own children will change.
What'd you say? Yeah. If you need some help, I can always help you get up. Hey. Well, welcome and thank you for joining me, wrapping up this beautiful conference event today. My name is Leslie Persky. I'm traveling from Cleveland today to be with you. I'm a certified sound healing practitioner and owner and founder of Cleveland Sound Healing. A sound bath is an opportunity to tune in, tune out the noise, the outside world, and tune in and listen to these different healing sounds, these frequencies, these vibration. And as you start to listen to them, noticing the sensations you're experiencing in your physical, your mental, your emotional body. Sound travels where it needs to. Where there's any parts that might not be in their natural state at which they like to vibrate at, it's going to help to bring those areas back into balance. And so because of this, you can experience sensations in sound bath, physically, mentally, emotionally. The most common sensations are changes in body temperature. There might be a part of your body that gets cold, gets hot, or it might be your entire body. It is very common to get a little bit cold by the end of a sound bath because of brainwave entrainment is happening. Our brain waves are moving from an active state to a calm, dreamlike state. And so because of that, our breathing starts to slow, our heart rate starts to drop, and our body temperature starts to. You can also experience some tingling sensations in a part of your body or entire body. Little micro movements, an area might get a little bit of tension, and these are just something to release. You can have your eyes closed and have some colors that kind of move in and out in different colors. Some people even get even more visuals. Some people experience smells. Some people hear a sound and it brings back the memory of someone, something. My Koshi chimes that I like to use always remind me of being a young girl, being in a garden, with berries and butterflies. So really anything and everything is possible. If there's anything that you experience that you are unsure of, please don't hesitate to see me at the end. Those are just some of the common sensations. The last one is a lot of people fall asleep, and that's okay. Some people start to snore.
And that's okay if you do. When we're in that deep state of sleep, is when our body's innate ability to start to heal for repairs. The last other thing I'll mention is some people feel like they're in this kind of like they think they're asleep, they're in that dreamlike state, and that can happen as well. I'm going to start by just getting us into this triggering this what we call this relaxation response. I will invite you to close your eyes, just take some deep breaths. We'll do a little bit of a body scan as I start to work with some instruments. I will be moving around the room with some of my instruments. And then at the end, I'm going to allow a minute or two of silence to allow the sounds to absorb in. And then I will you'll listen to my voice and I'll start to ask you to take some deep breaths, invite some movement back into your body. I'm sure those of you that are lying down are back up into sleep position. Any questions? All right. So I'm going to invite you to start to, for those of you lying down, to lie down and find your comfortable lying down position. Those of you seated, just finding that support in your chair. Maybe that's your feet crossed. Maybe that's your feet firm on the ground. Whatever feels comfortable to you. And then starting to soften your eyes, feel comfortable, allowing your eyelids to close. And just taking a few moments to just bring awareness to your breath. It's natural breath. Seeing how you feel physical body, mental body. Tight elbows.
Starting to invite some small movements that push your body. Really with the circles, these ankle circles, bottom levels, heads, knees. Come down, listen as everybody is move right around. Pull out wide, left knees together. Right to go. Right extension. Those of you lying down, there over the side, also upwards, further down. Let's go. This is you smile. I'm saying to you, stating out in the morning, and you have silence, but even inviting you down and you know, losses and praise. We invite you to travel and then that would be free. Hard work of lying there and feels good. Wishing all health and body and peace and mind and health. Shared sound and we share
Question, how's everybody feel?
Well, thank you so much. I'll be. If you have any questions or would like to chat with me, please don't hesitate to come see me. Okay, thank you.
Thank you.
Thank you. Okay, so we're gonna. Let me get up. Head over to the other room and then we'll have the last closing statements and then there will be cocktails and drinks for those who would like to do. Sound is great. So weird. I guess